Good afternoon. My name is Kathleen Borain, and I serve as the Maryland Insurance Commissioner. And I'm delighted to welcome you today to the first of several listening sessions that the Maryland Insurance Administration will be conducting this year to help us more fully understand the experiences of specific communities relating to insurance. These listening sessions will assist us in our enforcement of Maryland's insurance laws, in our development of educational tools, guides, and programs, and in our ability to be an informed resource and guide to the public policymakers in the General Assembly. Today's listening session is entitled Access to Healthcare Through Insurance for Women and Their Dependents. And I'm joined today by colleagues from the Maryland Health Connection and the Maryland Department of Health as we hear from invited panelists and consumers about the role that insurance plays in enabling women to access healthcare for themselves and their dependents, and where gaps, challenges, confusion, and barriers exist. You will find a link to today's agenda in the Zoom chat box. And if you have not signed up to speak but wish to be heard, please use the chat function to identify yourself and indicate that you would like to speak. If we have time at the end of the planned program, we will call on you, unmute you, and give you the opportunity to share your thoughts and your story. For those of you who are not aware, the Maryland Insurance Administration is the state agency that enforces the laws of the state as they relate to an insurance. And an important part of our work is responding to consumer concerns. And the MIA is here both to educate Marylanders, to answer questions about insurance, and to investigate complaints about the insurance companies and insurance professionals that we license and regulate. With me today is Greg DeWar, the Deputy Insurance Commissioner.
Hello, thank you, Commissioner.
Joy Hatchett, the Associate Commissioner for Consumer Education and Advocacy.
Good afternoon, everyone.
And Craig I, our Director of Communications.
Hello, everyone.
I would also like to introduce my colleagues from other state agencies and give them each a moment to share the mission of their state agencies. So first, let me introduce Michelle Eberly, who's the Executive Director of the Maryland Health Connection.
Thank you, Commissioner Borain. I'm delighted to be here, and I'm so appreciative of Maryland Insurance Administration for putting this forum together. It's so important. As you stated, I'm the Executive Director for Maryland Health Benefit Exchange, which operates Maryland Health Connection. We are the state's marketplace for health insurance, and our mission is to make sure that every Marylander has access to affordable health coverage and has health coverage for them and their families. We've done a pretty good job. We have 94% of all Marylanders have some form of health insurance, but our goal is to get as near to 100% as we can. So we're consistently trying to do that. And we'll be talking more today about coverage and options for women and children, but part of the Affordable Care Act from which we were born really is meant to protect women and children and provide healthcare opportunities. So through mandated benefits, such as making sure that every woman can have a mammogram without any cost to herself, making sure that children get immunizations, that they can go to a primary care doctor and get that school physical. So there's lots of ways that the Affordable Care Act has helped women and children with health care. And at Maryland Health Connection, we hope to make it easy for everyone to enroll. And in fact, 20% of all Marylanders do come through Maryland Health Connection, whether that's for private commercial insurance or for Medicaid public insurance. So we're thrilled to be able to play a part in that role.
Thank you, Michelle. We know that the Maryland Health Connection is a critical part of the state's health insurance ecosystem. And I know that you and your team are always looking at ways to better design. And I think today we'll learn a lot about whether or not there are some gaps and some other things we ought to be considering. So next, I would like to introduce Shelly Chu, who is with the Women's Health Division. I'm the Director of the Maternal and Child Health Bureau for the Maryland Department of Health.
Hi, thank you so much, Commissioner Moraine, for inviting us as well. Good afternoon, everyone. I'm really excited and delighted to be here today. And I also want to acknowledge my colleagues who are here from the Department of Health and specifically with the Bureau of Maternal and Child Health. And so I will let them also introduce themselves before talking more about our Bureau.
That's
Hi,
great.
good afternoon, everyone. And so sorry to interrupt. My name is Alina Troxel. I'm the Deputy Director for the Maternal and Child Health Bureau. It's a pleasure to be here.
Good afternoon. My name is Colleen Wilburn. I'm the manager for the Maternal and Child Health Services Federal Block Grant.
Oh, well, thank you again for this invitation, and just really looking forward to this listening session and just hearing just from everyone as well. As was mentioned, my name is Dr. Shelly Chu. I'm the director for the Bureau of Maternal and Child Health, and I'm with the Maryland Department of Health. And as a Bureau, we're so lucky to be working with so many wonderful partners, and I'm so happy to see them here today. And our mission is really, how do we promote and improve the health of the well-being of women, children, and families, and also to see how do we improve outcomes, but also how do we eliminate and reduce inequities as well. And so, we work along the life course cycle. We have many initiatives, and really what we want to see is just strengthening and supporting the maternal and child health systems of care so that there is availability and accessibility of just really high quality preventive primary and specialty care services as well. So making sure that access to insurance and having insurance coverage, it is very important for us. Of note, a statewide initiative, we are focused very much on maternal health and making sure that we are decreasing disparities. And specifically, we are looking to at decreasing maternal mortality and severe maternal morbidity, looking at both to decrease both in outcomes and in disparities. As you know, sort of nationally and even in Maryland, that right now, the maternal mortality rate, there is a disparity where the Black maternal mortality rate is 4 times that of the maternal mortality rate for those of who are white. And then with severe maternal morbidity, that is a host of conditions, including bleeding, need to be transferred to the intensive care unit. And we're also seeing disparities there nationally and then also in the state as well. And so today's session will be also really helpful as we are developing as part of the Maternal Health Improvement Task Force, maternal health strategic plan as well. And so as part of that maternal health strategic plan, there's 5 main goals that we're hoping to work under. So the first one is, how do we promote equity and mobilize against racism? 2 is achieving maternal health through a life course model. So looking at both during the prenatal period, but even, even before conception, because we know that optimizing your health beforehand is also important. And then also looking during birthing and then also in the postpartum and interconception period. We're also looking to strengthen families and communities, and that's where really the social determinants of health, those conditions in which we live that also affect our health becomes really important. And then the 4th goal is really looking at data. How do we improve availability of access and utilization of data to make informed decisions? And then the 5th goal is really, how do we look at develop a maternal health provider workforce that would be available, accessible, and culturally competent as well. So, this listening session is just very timely, and we're just so grateful of this opportunity to be invited. And so thank you very much.
Absolutely. Well, we are delighted that you were able to join us today for what I think is a really critical topic. And we do have a very full agenda, and I am just so grateful and that so many people agreed to come and help make sure that we are as informed as we can possibly be. One of the things that I've learned as commissioner is that while we have lots of sources of information and resources, there is nothing that is as important as really what I call boots on the ground, or having your ear to the ground and listening to the stories of individual people, and particularly providers, because providers are, particularly with regard to healthcare, are the ones who are in between often the insurance company and the individual as they work through different treatment modalities, and what is covered and what isn't, and what those gaps and barriers may be. So I'm excited to hear today from so many providers and advocates and individual patients about what their stories are. So with that, we will begin with our insurance carrier panel. There are two companies that we will hear from, CareFirst and Kaiser. And with respect to CareFirst, Blue Cross Blue Shield, we will welcome Sherry Guy, who's the Senior Regulatory and Policy Analyst for the Public Policy and Government Affairs Division. And we will also hear from Gracelynn Mcdermott, who's a Vice President at Kaiser. They will each give separate presentations. And Sherry, welcome. Thank you for coming today.
Good afternoon. Thank you so much, Commissioner Bering and members of the public. I appreciate the opportunity to give CareFirst perspective on this very important topic today. As Commissioner Bering mentioned, my name is Sherry, and I'm a Senior Policy and Regulatory Analyst with CareFirst Blue Cross Blue Shield. CareFirst is a not-for-profit health insurer in Maryland, DC, and Northern Virginia. We are focused on driving the transformation of healthcare experience for the better, and we're also committed to advancing equity for our members and communities. Next slide, please. So as we have seen, the devastating impact of COVID-19 pandemic are not just on people's health, but all other aspects of their lives as well. We know working parents are feeling the immense pressure of juggling both work and home demands, often without available or adequate childcare. We have also seen significant job losses as a result of the pandemic, especially for women. As you can see on the slide, 32.1% of women between age 25 to 44 dropped out of the workforce due to childcare issues, compared to only 25.3% men. More women were also not working compared to men across all age groups. In addition, job losses hit non-college educated women the hardest. As you can see on the graph, last April, when the pandemic first began, only 36% of non-college educated women were employed. These serious economic consequences of COVID-19 meant that many are unable to afford health insurance premiums or costs of care. And these job losses also led to many individuals and families losing their employer-sponsored coverage. Next slide, please. So we want to share some resources for those who have lost their coverage to access health insurance again. As mentioned before, Maryland Health Connection has extended their special COVID-19 enrollment period until Saturday, May 15th, so that more Marylanders have time to sign up for health coverage again. The MIA has also prohibited terminations due to non-payment of premiums. And on the federal level, recently, Congress passed its latest COVID-19 relief package, which included many direct relief measures, such as the $1,400 direct payment relief, expanded Medicaid coverage for pregnant women, enhanced tax credits on the individual marketplaces like the Maryland Health Connection, and COBRA subsidies. And lastly, health insurers in the region, including CareFirst, have implemented a number of relief measures to improve access to access coverage across the state. Next slide, please. So now I want to pivot specifically to coverage for women and their dependents, which is the topic of the listening session today. We recognize that some challenges and opportunities still exist to improve access to coverage for expecting mothers and their dependents. Across the country, we know recently Health Affairs published the data suggesting 1 in 3 pregnant women experience month-to-month changing insurance types, or in other words, health insurance churn. And currently, existing Maryland law requires coverage for newborns only 30 days after birth. We know that Medicaid currently only covers low-income pregnant women 60 days after birth as well. So now, given the disproportionate impact of the pandemic on women and their children, additional actions are being taken both on the state and federal level to extend coverage and reduce perinatal insurance churn. So specifically, for example, during this current legislative session, Care First supported a Maryland bill, SB 923, to extend Medicaid coverage for eligible low-income pregnant women to 12 months postpartum, as permitted by the federal law. And on the federal level, in addition to some of the direct relief measures I mentioned before, the latest COVID-19 relief package also provides states with a new option for 5 years to expand Medicaid eligibility to women for 12 months postpartum beyond the current 60-day limit. This federal legislation also provides increased amount of cash voucher value under the WIC program and provides additional support for the education system, childcare, extended paid family and medical leave, all addressing the social determinants of health factors that are essential to women's health and access to coverage. Next slide, please. And specifically during the pandemic, Care First quickly shifted to help meeting the immediate health, social, and economic needs in our communities. For example, we have extended our grace period for non-payment of premiums beyond the mandated 30 days to 2 months. We provided millions of premium credits and rebates for individual, small group, and large group customers. We're currently covering all costs associated with FDA authorized COVID-19 vaccines and have waived all cost sharing for COVID-19 testing and treatment for fully insured members as well. Specifically for our Medicaid members, including the 6,000 pregnant women, we're conducting proactive outreach to provide clinical support and education, connecting them to existing community resources and helping them with vaccine appointments. Next slide, please. And I just want to mention, Care First has been focused on improving maternal and reducing outcome disparities for a long time. Since 2009, we have invested more than 20 million in this specific area. For example, in Baltimore City, we provided more than 10 million since 2009 to support the Be More for Healthy Babies initiative. Through services like home visiting and central triaging, this program resulted in 15 to 30% decrease in infant mortality rate and a significant 75% decrease in teen birth rate. In 2018, we have also supported some key maternal child health programming across the state of Maryland, such as supporting some prenatal care and home visiting services provided by Prince George's County Health Department. And in 2019, we released some additional funding to further expand access to care and support pregnant mothers. Next slide, please. Moving forward, Care First will continue to evaluate and implement ways that we can lend support to our members and communities and fulfill our mission to driving transformation of the healthcare experience. Thank you again for the opportunity to present today, and I will be happy to answer any questions at the end. Thank you.
Thank you very much. I very much appreciate your presentation. We have a pretty packed agenda. If any of the other members of state agencies have any questions that they would like to ask, please feel free to do so. And I think, Michelle, you may have a comment that you might want to make about the extension of the SEP.
Yes, the SEP has been extended to August 15th for the special enrollment.
That's great. And that will put it in alignment with the federal extension as well. That is terrific. So thank you very much, Sherry. We appreciate your comments. If we could hear from Gracelynn Mcdermott at Kaiser.
Thank you very much. Can you hear me now?
I can. Thank you.
Okay,
nice
great.
to see you again.
Nice to see you. I am really happy to be here, and I do appreciate the invitation and the opportunity to speak to all of you. For those of you who are not familiar with Kaiser Permanente, know that our model of care is making a difference not only in women's health, but throughout the entire care continuum. Here in the Mid-Atlantic, we have served the community for 40 years, and we consider ourselves to be a true partner in health for our members and the communities that we serve. And our model of integrated high quality care is unique in that we are not just a health insurer, but we're also a healthcare provider. We have a deep-rooted commitment to community health of women in Maryland. So to that end, I want to jump to slide 8 to talk specifically about this commitment. There we go. So the KP standard of healthcare for women provides a lifelong comprehensive total healthcare. It's our proactive integrative model of care at KP that makes a difference in the lives of women every day. And I'll give you an example. You know, we have a member that can go in for an eye exam, and she may, during that eye exam, be told that she's overdue for her mammogram. She can likely have her mammogram be scheduled that same day without even leaving the building. And while women often have an agonizing wait for their mammogram results, at Kaiser Permanente, we pride ourselves in providing our members with results right away whenever possible. And this happens the majority of the time. In fact, 3 weeks ago, I personally received my mammogram results in less than 30 minutes of leaving the office, medical center. We have the highest breast cancer survival rates compared to the national survival rates for females, and that's across all races. If you go to the next slide. So our key in treating women, particularly for breast cancer, is all about convenience, follow-up, and comfort. And as I explained in the previous example, you know, I talked about the convenience and the fast follow-up, but we also use FDA-approved curved paddles in our largest medical centers for maximum comfort. And anybody that's a woman that's been gone through her mammogram knows it's not necessarily the most pleasant of experiences. So we go to slide 11. I want to talk about some breast cancer facts that I believe that most of this will not be new to you. We know that breast cancer is devastating to women and their families. This disease kills more than 42,000 women each year and is the second leading cause of death in the United States. But we also know that early detection of breast cancer and other cancers offer the best chance for survival. In fact, 99% of women with breast cancer survive when their cancer is caught early. And the survival rate drops by 27% when the cancer spreads. So at Kaiser Permanente, we are taking this fact to heart and really to health. And if you go to the next slide, you can see that we are really making a difference for women. Women at Kaiser Permanente don't just depend on remembering their annual mammogram, like I mentioned. If they come from another appointment, whether it's an eye exam, a physical, or a vaccination, if they are due for a mammogram, they can book the appointment right there, and they often get it during their same visit. And the numbers here show that in our region, we're screening our women with mammograms at higher rates than others because of that model. You go to the next slide, and I mentioned earlier that it's across all races. So what you can see here is whether they are Black or white, women with Kaiser Permanente in the Mid-Atlantic states, and this is specific to Mid-Atlantic, have better survival rates compared with the national average. You can see that it's almost 91% for Black women and almost 98% for white women, compared to the low 80s for Blacks and low 90s for whites on the national perspective. You can go to the next slide, and let's shift a bit to cervical cancer, because this is another devastating disease for women with 36,000 new cases each year and thousands of deaths. And again, cervical cancer survival is dependent on early detection. 5-year survival for cervical cancer is 92% when the cancer is caught when it's still local. You know, go to the next slide. And similar, our approach to cervical cancer is catching it early through regular screening. Similar to mammograms, when a woman comes into one of our facilities and is due for cervical cancer screen, they're going to be offered the opportunity to schedule that screening that day or at a future date. And if you go to the next slide, similarly, you can see that our numbers show that we are getting these screenings in for our members at a much higher rate than others in the regions and well above the national average. So at Kaiser Permanente, we recognize that 80% of health comes from the outside of the doctor's office. And this was something that Dr. Chu mentioned. We approach total health as meeting the needs of our members and our community well beyond our medical center. So if you go to slide 18, it's part of our mission to improve the health of our members and the communities that we serve. We know that when an individual's health is more affected by the community and the social supports that they have. And that includes safe, stable housing, adequate, nutritious food, and reliable, affordable transportation. These are all factors that impact our ability to thrive. Many Maryland households are forced frequently to make difficult choices, such as skipping preventative health care, accredited childcare, healthy food, or car insurance. And these trade-offs are things that threaten their health, their safety, and their future. So we aim to improve community health by improving the economic conditions of community members and addressing an individual's unmet mental and social healthcare needs. You'll see in the next slide that community health is the core to who we are. We know that we have to continue to build stronger social systems in support of a healthier community. And as a society, we need to consider all the factors of social health and their impact on the community and the public health at large. Our community health strategy is driven by what we call impact investing. So we assess the healthcare needs of the communities in a broad context, including job markets and the availability of affordable housing, while identifying ways to improve life opportunities. We believe that these healthcare investments can support community health by offering access to living wage jobs, steady income, stable housing, and nutritious food. And we're proud to have awarded almost $900,000 in grants to community organizations and nonprofits throughout the Mid-Atlantic region. Earlier this year, we announced the expansion of what's called the Mid-Atlantic Community Network. This program is thriving in Baltimore, DC, and suburban Maryland. Primarily, it's a technology platform, and it's powered by Unite Us. And what it does, it connects individuals to critical healthcare and social needs, such as housing, food, employment, transportation, behavioral health, and utilities assistance. The COVID pandemic, you heard Care First talk a lot about the effects as it has on the community, and it has led to a spike in the need of social services across the region, as we see that our individuals are struggling to overcome unemployment, childcare challenges, lack of adequate healthcare, and hunger. And we are using the doctor's office, asking questions within the doctor's office and connecting those individuals to those social needs that can support the gaps in healthcare. Next slide. I would be remiss if I did not touch on our fight to end racism and promote equity. And I'm proud to be part of an organization that's committed to eliminating health disparities and creating that equity in our communities. We have a deep-seated, long-standing commitment to equity, inclusion, and diversity. And here in the Mid-Atlantic region, we take that to heart because we know that of the healthcare and the racial and ethnic disparities in care and outcome, that through proactive outreach, we can provide high quality evidence-based care. So some more examples. One area that we've made us a significant difference is in colon cancer survival rates. Colorectal cancer disproportionately affects Blacks in the United States. However, when you come to Kaiser Permanente, we do not have racial or ethnic disparities in survival rates among our Kaiser Permanente patients. And additionally, Kaiser Permanente members in the Mid-Atlantic states have higher colorectal cancer survival rates, 78%, compared to the national survival rate, which is 64%. So another example can go around in terms of diabetes. We know in this particular region that diabetes is something that is prevalent for Blacks and Hispanics. We have lower rates of death when compared to those national CDC metrics. And I've already talked to you about the breast cancer survival rates. So across all races, Kaiser Permanente patients have lower death rates compared to the national CDC metrics for hypertension, diabetes, colorectal cancer, and breast cancer. And we're also committed to eliminating those health disparities and creating that care equity across the communities. So I'll finish out the last slide. We have doubled down on our longstanding commitment to equity, inclusion, and diversity through our actions and through our impact investments. And we can continue to be informed by data, as was mentioned earlier, to offer medical excellence to achieve those equitable health outcomes. We are absolutely proud of our successes in addressing women's health specifically. And as we come through this pandemic, we continue to be focused on medical excellence and our convenient, connected, and personalized care for our members and community members, helping to achieve total health for all, because we can't just look at women's health as an isolated piece of the puzzle. We need to ensure that the wraparound services exist to integrate social health into that model of care. And I want to point out that April 11th through 17th of 2021 is Black Maternal Health Week. That has been launched by Black Mamas Matter Alliance in response to the growing concerns about disparities in maternal morbidity and mortality that are affecting Black women in America. And Kaiser Permanente is participating in that Black Maternal Health Week. So we're looking forward to that and are very, very excited. And thank you again.
Thank you very much. I have two questions for you. The first one is, your metrics are impressive, and I'm interested in if you could share with us some of the reasons why you have found that you've been able to close those gaps in disparities along racial lines in some areas.
Yeah, it's all about, as I mentioned, our integrated model. Kaiser Permanente was one of the earlier insurance companies that had an integrated health medical record system. So when you go into a medical record system, whether you're going to your primary care doctor or you're going to your specialist or you're just going into vision, they all can have access and see into your medical record. So if, like I mentioned, going to the eye doctor, the optometrist is looking at my record and realizes that I haven't had my mammogram. And she will right then and there say, would you like me to schedule this for you? I can do it today. I can do it in a couple of days and move forward. And then getting the data back, like I said, within 30 minutes to an hour in the majority of the time, getting that data back. And then once that's back, if there is a finding, we turn that around the next day to get whatever biopsies are needed and get people into surgery. And then we wrap around that care through all of the specialists around so that they have a targeted method of care that is really going to help them survive and get over it. So it really is that integrated model.
That's very helpful. Thank you. The second question I have is a little wonky, but I'm going to ask it anyway. And that is, I appreciate that there are things that are really not covered by insurance, nor should they be, like things like diapers or formula or bottles or breast pumps or any other, number of things that women need in order to take care of, really, and any child provider needs in order to take care of a child that's in their care. And yet, what we've seen, it probably escalated more within the pandemic are things like, diaper banks that can't find diapers. And so I'm interested in the role that insurance plays in those types of what are ancillary, from the perspective of insurance, but have such a deep impact on child health and, mom or dad as primary caretaker, mental health and bonding, and frankly, the inability just to have a steady supply of diapers, can lead to really serious medical condition for children. And so, while I appreciate that no one's ever going to expect diapers to be a covered benefit under an insurance policy, what are the ways in which, as you begin to think about, when you talk about broader community buying power, discounts, coalitions, connections, can you speak to that?
And that's exactly it. I think I'm very excited of what we've done with the Maryland Community Network, being able to connect these individuals that we're connecting these women to are nonprofit organizations that are already operating in the state of Maryland. And so these nonprofits, they do specialize in women's care. So they're the ones that will be handing out the diapers. They're the ones that can help with the food banks and what have you. And oftentimes women aren't aware or they're afraid to ask for it. So it's almost as if we can give them a prescription to go to connect in that social connector and take it from there. And I think that's the future, is if we can allow, and I'm speaking for myself, if we can allow that primary care physician or that OBGYN issue a prescription for those basic social needs, that would go a very, very long way in protecting women and children and getting them the care that they need.
Thank you very much for your presentation and for those answers. Very, very helpful. So I appreciate our provider panels and sharing with us the kinds of things that they're doing in the state of Maryland to advance access to care and quality care and better health outcomes. So thank you for that. We're now going to move to our panels that are from, we're going to start with provider panels. And we're very fortunate to have with us today a number of providers. And I'd like to introduce first Michelle Manahan, who is a board member of MedChi. Thanks for participating with us today.
Thank you for having me. Yeah, I wanted to start by just saying that I am very, very happy to participate in this group today and to hear what everyone else has to say, and just share a couple of comments from the MedChi perspective, as well as the perspective of being a plastic surgeon who treats women for surgical issues related to women's health, and also as like many of us are, patients ourselves at different times in our lives. And I think that the three things that I really am hopeful in terms of opportunities to build partnerships are the working together to really come up with criteria that are clinically meaningful in terms of coverage. Also working on messaging both from the provider side to our patients, and I imagine from the insurance provider side to the consumer in terms of the reality of the insurance coverage situations. And then finally, just working to decrease from all angles the administrative obstacles that we all encounter during our daily work in our professions, as well as on the patient side.
Thank you. That's an interesting phrase, clinically meaningful coverage. What do you mean by that?
Well, I think most simply working to really look at criteria for coverage in policies that make sense from the coverer's perspective, from the clinician's perspective, and from the patient's perspective, where it all comes together. What are the driving forces that seek a patient, or that cause a patient to seek some sort of medical care? What are the clinical expertise? What are the things that seem relevant in that discussion? And then from the, again, I'm speaking out of turn when I'm trying to wear a hat of somebody else's perspective, but I imagine then from the insurance carrier's perspective, what makes sense in terms of being able to provide reasonable coverage that makes financial sense as well.
Thank you for that perspective.
Thank you for letting me share it.
No, absolutely. Any other comments for us today?
No, those were my main things that I wanted to put out there. Thank you.
Well, thank you for participating. You know, we appreciate what MedChi does and for your willingness to be here today. We also are happy to welcome Elizabeth Lazzaro, who is the program director for the MCHP program for the Baltimore County Department of Health. And I believe we also have Gracelynn Jones, who is the program eligibility supervisor for that same program. Welcome to both of you, and happy to hear from you and your experiences with regard to health insurance access, how health insurance helps women and their dependents access health care.
Hello, hi, my name is Gracelynn Jones, and I have the honor of speaking for Baltimore County today. At the Baltimore County Department of Health, we provide a range of options for uninsured women to have access to needed healthcare services. The first step is to apply for health coverage through the Maryland Health Connection. Individuals can apply over the phone at 1-855-642-8572, online at marylandhealthconnection.gov, or through their local health department. Due to the pandemic, local health departments have the ability to complete applications over the phone. The main number for the Maryland Children's Health Program for Baltimore County is 410-887-2957. And our hours of operation are Monday to Friday, 8:30 a.m. to 4:30 p.m. Prior to the pandemic, the local health department can only process applications face-to-face. Please contact your local health department in advance for office hours. If an individual is deemed ineligible for Medicaid due to income or immigration status in the country, they may be able to purchase a health plan. Maryland Health Connection will provide information on health plans, including coverage and costs. The plans range in price based on coverage level. For those individuals who are not eligible for healthcare through Medicaid or a qualified health plan, services both through the health department as well as outside of the health department are shared with the client. Some services for the uninsured within the Baltimore County Department of Health include cancer programs. Services include education and screening services for income and age eligible residents. Cancer diagnosis and treatment services may be available as well. Baltimore County Department of Health Dental Access and Referral Program. Dental services are available for county residents from birth to age 21 and age 60 years old and older who do not have any form of dental coverage. Cost of services is based on a sliding scale fee. Family planning services, counseling, and a full range of family planning and birth control methods are provided. Pregnancy testing as well as testing for sexually transmitted disease and treatment are also available. Fees are based on ability to pay. However, no one will be turned away if they do not have the funds to pay. Well Child Clinic provides preventive care for residents from birth to age 21 years of age. Mental health services, a wide range of services are offered to help those with mental illness, including medication assistance. Baltimore County Crisis Response System, which is a 24-hour hotline available to those in mental, behavioral, and emotional crisis. HIV testing. HIV testing is free and is also available in multiple locations as well as an in-home testing kit. For more information about sites, locations, and availability, call your local health department. HIV Case Management. Staff will assist HIV positive individuals by applying for individual coverage. Case managers can assist with linkage to MedApp, a program which ensures people living with HIV/AIDS in Maryland have access to the medication they need to stay healthy. Hepatitis C testing, as well as SHARP's disposable services. Some services for the uninsured outside of Baltimore County Department of Health include providing information on federally qualified health centers, including location, services offered, and how to access services. Providing an option on obtaining services through the CVS Minute Clinic, which have a clear list of services offered, as well as upfront list of associated costs. Referral for dental care through the University of Maryland Dental School provides complete family and dental care. Providing information on prescription assistance programs like Needy Meds, prescription drug cards, prescription discount programs. For more information on services provided to the uninsured, please contact the partnership program with the Baltimore County Department of Health. The partnership program is staffed with bilingual case managers who speak Spanish and English. They will work with the individuals to access needed healthcare services, both inside and outside the health department. You can reach partnership at 410-887-8629. Thank you.
Thank you very much for that information. It's extremely helpful and valuable, and I appreciate the fact that you were able to provide it to people today. I'm going to apologize to everybody because I apparently cannot read or pay attention to a schedule, and so I jumped through the panels, and but I'm going to bring us back on track now, and I'm going to invite Ms. Givens, who is with the Chesapeake Healthcare and a financial eligibility specialist with that group, to speak to us about what you experience and what you see on the role that insurance plays in enabling women and their dependents to access healthcare, and probably most importantly, what those of us who are state officials need to hear about where there are gaps and where there are still barriers.
Thank you very much, Commissioner, and everyone, for allowing me a chance to speak on behalf of Chesapeake Healthcare. My name is Deirdre Givens. I am, in addition to a financial eligibility specialist, I'm actually a certified application counselor as well. So Chesapeake Healthcare is a federally qualified health center consisting of 6 major disciplines, providing care to the 3 lower counties of Maryland, Wycomico, Worcester, and Somerset. So we offer adult medicine, pediatrics, OBGYN, mental health, dental, and we also have pharmacies. Chesapeake Healthcare is currently the primary OB provider for Wycomico, Worcester, and Somerset counties, and made a really wise decision to become a CAC sponsoring entity, which allows us to address the needs of uninsured or underinsured patients as they enter the office for appointments. So we now have 4 full-time CACs. Each of us are placed at the busiest centers, 3 offices in Salisbury, including adult medicine, pediatrics, OBGYN, and a multi-purpose office in Princess Anne that includes pretty much all disciplines. And then we float to the other offices as needed. I'm physically located at the OBGYN office in Salisbury, which serves approximately 16,000 patients. On a busy day, we may have 12 providers on staff. So my days are pretty busy. My interactions with pediatric patients is normally in regards to adding newborns to Maryland Health Connection applications after the mother's postpartum visits, or if there's been a loss of coverage for the child. We have also developed a very close relationship and sharing collaborative efforts with the health departments here on the shore, as well as the region's connector entity, the Lower Shore Health Insurance Assistance Program, or LSHIP. And the reason being is that with the pandemic causing a major impact to access to assistance, we rely very heavily on the relationship that we've developed with those agencies. Some of the issues that patients encounter, I believe, is related to policy, and others are administrative or technical. With the government offices working from home and not being able to provide that face-to-face assistance, and the fact that we have, as CACs, worked throughout the whole pandemic, with the fact that we're accessible, the demand for our services has really increased, but we work at a disadvantage. We utilize the consumer portal, which doesn't offer the same type of access or ability to navigate the Maryland Health Connection, or what is afforded to navigators or MCHIP staff. So what we find is patients tend to complain of their inability to access government agencies right now, long wait times, system glitches that might require a navigator or government employees access to investigate, identify, excuse me, or resolve an issue. So if, for example, this is something that I encounter, if an account is initiated via the worker portal, and then the consumer visits me for assistance because they're here for an appointment, it might require me to start a new account, a new application via the consumer portal, which might present a problem. For example, a pregnant minor that enters the office that may have coverage through a parent that has lapsed in coverage. If that has been initiated through the worker portal, there's nothing that I can do except to establish a new consumer portal, which I can't do because it's a minor. Another example of system issues or policy issue might be changing an MCO outside of the annual right to change. That used to be a major problem for me and the patients that I encountered when we were non-par with all of the MCOs. So for example, if someone that lives in Ocean City came to an appointment without insurance, or had established, let's say they established an application and an MCO was randomly assigned, then unfortunately there was nothing that I could do to switch an MCO. Even if they may be experiencing issues with the pregnancy maybe not being viable, they were expected to drive to Easton, which is over an hour away, for care. Fortunately, we don't really have to worry about that here within our office anymore because we are par with all of the MCOs, but that doesn't mean that patients in this region still experience that issue. There is one of the things that I did to prepare for this session, because I didn't want it to be based purely on my perspective and what I do in my function, but I also inquired with the clinical nurse manager, the case manager here in this office, and OBGY billing to see what they encounter as far as challenges that are experienced with our patients in the billing. So one of the issues that the case manager pointed out was transportation. That's a huge barrier here. For example, the patient may not have the financial means to pay for transportation and medical appointments. And with the fact that we're in a rural situation, it's very different than across the bridge in the metro area. If the patient lives within 3/4 of a mile of a bus line, and we're not talking about transit, metro transit, we're talking about a bus line that might run through every single county before the patient gets to the location where they're having their appointment. They may be expected to take that bus route. So as an example, there's a bus stop here in the medical center where my building is located. About an 8-minute walk away from here is our pediatrics office. So someone living on that bus route may be dropped off in this center and then expected to walk across east and westbound Route 50 to get to the pediatrics office. And if you can imagine, what if it's inclement weather? What if the mother has a baby and a toddler? Can you imagine trying to make that trek to be able to get to the doctor? Another issue with the pandemic, we have instituted, of course, measures to try to protect everyone. So visitors are not permitted. So that creates an issue as well. If a pregnant mother that has children that has no daycare available needs to come for an OB visit, what are they going to do with their kids? So sometimes, unfortunately, it means they may no-show or cancel. Medicaid transportation doesn't allow children to accompany an adult. So if the mother is coming for an appointment, they have no daycare, that's an issue. Let me try to collect my thoughts a little bit. There's so much that I want to touch upon.
Take your time because we want to hear from you.
Many of our patients are actually working mothers. They have employer-sponsored insurance, but many of these plans include very high deductibles, co-pays, co-insurance, or no maternity coverage at all. So what we have done to try to take advantage of the special enrollment periods, the special enrollment period due to the pandemic that has existed over the number of months, is we have sponsored our own special enrollment events. We have a conference center in the building where I'm located. So LSHIP and the MCHIP offices have provided their staff to assist us in sponsoring and holding these events. And I must say that it's been very effective, and we will probably continue this throughout the period of time that the special enrollment period has been extended. Our billing department, front office staff, history nurses are really diligent about screening for patients that may benefit from applying for secondary coverage, or those that are completely lacking coverage. I coordinate with them. I actually prepare a pamphlet of information as well as my business card to the history nurses so that folks are understanding that even though you may have employer-sponsored insurance or commercial insurance, you can still benefit from secondary coverage through Medicaid, which a lot of women are not aware of. There are women who have no insurance because they're self-employed, not offered insurance by their employer, or they may be overscaled financially to qualify for Medicaid, but might possibly decline a qualified health plan because of premium rates. There's a confusion, I believe, that exists because there's a lack of information or lack of knowledge as to where to find the information regarding the availability of pregnancy coverage throughout the Medicaid, through the Medicaid program. You'd be surprised how many women don't even take advantage of the fact that they could have those out-of-pocket expenses covered because they don't know that exists. So hopefully the information sheet that I provide, at least in this region, helps some to bring some awareness. For anyone that isn't eligible for financial assistance through the Maryland Health Connection, Chesapeake Healthcare does offer a sliding fee discount, discounted rates for delivery, office visits, and labs. And one of the other things that was mentioned to me by our case manager is that there appears to be a lack of literature in languages that would serve to help with patient compliance within our diverse immigrant population here in the community, especially related to hypertension and diabetes, which unfortunately, does cause major issues with some of our patients, and can, affect the pregnancy, especially high risk in terms of fetal demise. So with such a large population of Spanish and Haitian Creole immigrants in particular, language barriers can really lead to a lack of healthcare, late entry to care, and, of course, a delay to the start of OB care coupled with prevalence of health issues like the hypertension and diabetes is a huge concern. Challenges in terms of gaining access to healthcare through the Maryland Health Connection. Computer, internet access, email, cell phones are required to obtain benefits, and they're not always available. Areas where cell coverage is sparse or non-existent, such as Crisfield or Smith Island, makes it very difficult. Culturally, Smith Islanders kind of lack trust of outsiders, which our connector entity, LSHIP, tried to address by sending out one of their navigators by boat to try to interact with the island's occupants. So I guess all in all, the real challenges here on the shore would be the lack of information that would assist in making sure that everyone knows what's available to them, trying to address the language barriers, transportation, and then for us as CACs that have been really diligently trying to fill in for the staff that would normally be available through MCHIP and the navigators, it's a struggle. It really is a struggle. I can say personally, I have since March been assisting Wicomico County and Worcester County by helping to fill out emergency Medicaid applications because they require a signature. They did before the XO2 and XO3 applications were made available within the Maryland Health Connection, and I actually still do process them. So I gather that information, everything that's needed to accompany it as far as documentations, forward it over to the health department, and if need be, complete follow-up to make sure that medical assistance numbers have been assigned and provide that information as well to patients. If I were to make a plea to make things a bit easier, It would just be to have access to do simple things like search for pre-existing accounts. I can remember being selected for UTB testing when the system that we're currently using was being rolled out. And one of the functions that was going to be made available in the consumer portal was just to be able to simply search to see if there was already an existing account. When there are multiple accounts, it causes issues. Another thing would be to be able to have the ability to reset passwords. It cuts down, it makes our job a lot more expedient. We have to juggle a lot within this office. If I'm trying to capture a patient after, let's say, a history appointment where they've already been with a history nurse for an hour, and then I try to do what I've got to do within 15 to 20 minutes before they go get labs done and perhaps OB, their first OB appointment, it would make it a lot easier if we didn't have to try to track somebody down for assistance. I'm so thankful. I have to give a lot of praise though to Worcester County Health Department and LSHIP for providing us support, because we wouldn't be able to survive what we've been doing.
No,
So,
that's terrific. And your
thank you.
information is very helpful. I know that Michelle Everly has indicated in the chat that she's going to follow up with you directly to talk about this. And I know that many of your comments will be taken to heart by the folks that are here from the Maryland Department of Health, and you can expect some follow-up. You know, we don't have time this afternoon, but I do want to, you know, Joy and I will be in touch with you. I'm particularly
Thank you.
interested in this concept of gap coverage, and where you're seeing, you know, where people don't really need the full, they have some form of employer-sponsored, you know, healthcare, but as we all know, in certain plans, there's such a large deductible,
Right.
there's such a large gap. And, you know, what are ways in which we can fill that when employers don't have sort of options there, and people don't have a lot of economics. So very power-packed presentation.
Thank you.
Thank you very much. And we will all be following up with you, and really appreciate what you said today. But you know what else I really appreciate? I really appreciate your heart for service, because you are so passionate and so compassionate. And we are so fortunate to have someone like you taking care of
Thank you.
folks on the shore. So we see your heart coming through, and thank you for that.
Thank you.
Appreciate it. Well, we will now hear from Dr., and I hope I pronounce this correctly, Thulani Stewart, who is an OBGYN with Meritus Health, to give the perspective from Western Maryland.
Good afternoon. How are you?
I'm very well, thank you. Did I pronounce your first name correctly?
It's actually pronounced Tulani, like you're going to count
Tulani.
Lonnies, like one Lonnie, two Lonnie, three Lonnie, four, five Lonnie, six Lonnie, seven Lonnie more. So
Thank you.
Tulani. All
And
right.
welcome.
Thank you. I am glad that I'm going after Miss Givens, who's on the other end of the state. I'm on the western part of the state in Washington County in Hagerstown. As an OBGYN, I'm really grateful that Ms. Givens went before me so that many of the technical things have been addressed. I'm really only going to try to provide my experience as a provider. I've been in Western Maryland, Hagerstown since 2013. I'm originally from Tennessee, so I'm a transplant here. So I bring a unique perspective. But Hagerstown's population is slightly different than Baltimore racially. There's probably, in terms of the patients that I see, probably a larger percentage of white Caucasian patients as opposed to African-American or even Hispanic. We do have a population of Hispanic patients that is growing, and language barriers are somewhat of a concern. And having information that is in Spanish that they can understand is a concern. But I think one of the biggest concerns that faces all of our patients, and what I see, is a health literacy. They tend to not really understand health in general, and understand even less insurance in general. And currently, the way that it works is that the offices, the medical providers, health department, through social workers and other people who are involved in this insurance, are the providers of this information. But you've got to come to the doctor's office to get that information. And so there are many patients who are not coming to those providers and doctors' offices to even know that these options are available. So I think a good idea might be to try to look at providing this information in other forms other than from a health department or social worker, almost in the sense of advertising like everything else that is advertised, but that people already are coming to these entities already knowing what things are available, and they don't have to come to the entity to find out what's available. They already kind of know. I think that would be a great thing to try to institute. And we face all the same challenges. We face the challenges of transportation. We face the challenges of bus routes, and depending on where you live in the relationship to that bus route, whether you can get a bus route voucher or whether you can get a cab voucher and how many cab vouchers you can get. And in terms of my field of obstetrics and gynecology, if 39 weeks, 38 weeks pregnant, and you don't want to, many patients say, I'm just not going to walk. And so they just don't come. And their plan is to just show up to labor and delivery when they go into labor, which normally works out. But if you're trying to decrease the mortality and morbidity of pregnant women, my suggestion would be to try to look at more preventative things that go beyond before they get pregnant. The insurance that is provided that kind of kicks in, for lack of a better word, when women do become pregnant is great. But to prevent many of the things that cause increased mortality and morbidity during pregnancy really need to be addressed before they get pregnant. So in terms of obesity, hypertension, diabetes, those things, those are things that can be addressed, I think, if we could, prior to getting pregnant. And more of an approach of thinking as women who are pregnant, not only as providers or recipients of this healthcare, but maybe try to educate them to be as healthy as they can be, because I think every woman in the world is going to try to increase their child's health. If we can teach women how to be healthy, they will teach their children how to be healthy, and in time, we will have a healthier nation, I think. So I would like to see two things: maybe a greater dissemination of information to patients themselves or the consumers themselves, so they know what is available, how do they access it, and that information is not disseminated from coming to a healthcare provider. And aside, many of the patients in Washington County suffer from drug addiction or have had drug addiction, and there is a uneasiness with being involved in, I guess, large government organizations. And so they feel as though if I come and talk to someone about health insurance, you will get my information, and then that will lead to any kind of judicial ramifications that they've not been trying to avoid or whatever. The same thing, I think, exists in some form with people who are undocumented here, who do not have a social security number, who may be here undocumented. They are very wary about coming into these social situations also. And so many times they are the people who show up on labor and delivery with no prenatal care. And you ask them why, and they say, I didn't know I could get insurance, or I was afraid to come and get insurance, or, for whatever reason, but it's a lack of information, I think. So disseminating that information would be a great step. The other step is to try to maybe craft something that addresses these health concerns before they get pregnant, and to try to use women themselves as teachers to their children. I think those two things would go a long way. Thank you.
Well, thank you, Dr. Stewart. Within your patient population, do you see primarily people that have coverage through government-sponsored programs, or do you see mostly people who have private insurance or employer, insurance, which might not be an insurance company?
In my practice in Women's Health Center at Emeritus, mostly I would say maybe 60, maybe 65% of the patients are government and Medicaid. So they're state-sponsored Medicaid packages. And then the other portion is, we have a small percentage of portion of self-pay, probably 10%. We are in a unique position in Washington County. We border West Virginia and Pennsylvania. And because of Meritus's size, Meritus Hospital is the largest hospital in that little tri-state area. So we get a lot of patients who come from West Virginia or Pennsylvania, and we have a lot of patients who come who are self-pay. There's a large Mennonite population there in Western Maryland, and they come and just do self-pay. But the majority are state-sponsored in my practice.
Thank you very much. I appreciate
You're welcome.
that. We're now going to hear from Dawn Bullens, who's the Senior Director of Operations at the Institute for Gynecological Care at Mercy at the Weinberg Center for Women's Health at Mercy.
Hi, good afternoon. I'm Dawn Bullens. I am the Senior Director for the Institute for Gynecologic Care here at Mercy. I want to thank you for the opportunity to participate in today's listening session. It's been actually up to now, it's been very, very informative, and I think it's been really going well. I wanted to provide first some background as to who we are here at Mercy. So the Institute for Gynecologic Care is part of the Weinberg Center for Women's Health and Medicine. So our institution provides services. We tried to develop a place where women could go to collectively achieve all services that they needed. So we have our GYN oncologists, we have GYN, we have breast surgeons, we have plastics and reconstruction, we offer genetics counseling, and also have a women's imaging services line so that patients can come and full service get their needs covered. We also took it a little bit step further, and we created a Medi-Spa as well as a boutique, because we wanted patient wellness, female wellness is also important. So we sort of incorporated that into who and what we are as well. So I as well talked to a lot of different team members to kind of figure out where our concerns and our issues were. And in talking to them, we've kind of come up with two different areas that I would like to address, which is first, the patient's understanding of their insurance coverage. We're finding that seems to be a huge obstacle that patients are presenting to the office. A lot of what we do are cancer-related issues. So we're dealing with some really hardships and difficult things that we have to explain to patients and their need for surgery. And then that's when they're sort of learning the details of their insurance. They're not familiar with copays and deductibles, and that these things need to be paid in advance. And it's causing them hardships to make decisions between proceeding with a surgical procedure and or making the payments. Now, we at Mercy have many opportunities. We work with our teams who work to, if they need any kind of assistance through the state, we'll suggest that we go through that route. If not, Mercy does offer independent financial assistance. But it's interesting that the patients are continuously presenting and not really having a full-fledged understanding of what their insurance covers and doesn't cover. Some have exclusions that they were not even aware of, like if they had a pre-existing condition. The patients are somewhat finding that out when they present to any of our departments. So that was one of the bigger things that we talked with through our teams, was that it's just a lack of understanding for patients. And we know that patients get a ton of materials when they sign up for their coverage, but is it that it's too much and it inundates them? Is it just not broken down enough? So that's some of the issues we've been seeing with patients lately, and especially those who are getting coverage through like the Affordable Care Act. We're finding that they're picking plans that meet their budget, but then they also come with high deductibles that they are a little bit surprised to find out, and maybe they're not, but that's the impression we're getting, that this is like the first time they're hearing that they have that out-of-pocket expense, and then they start to worry and be concerned because now the expenses are outweighing some of the options. So I just wanted to make sure that everybody was sort of aware of that seems to be one of our biggest concerns, is just that communication piece between what the patients understand their coverage is and what they're actually, when they get here, there seems to be some lack of understanding.
And I think we'll probably want to follow up with you as well, or Joy will, if you're really hearing circumstances where there are issues with pre-existing conditions, and what exactly that product is in those circumstances are.
Okay.
Because as we know, that one of the primary goals of the ACA was to not have issues with pre-existing conditions. So it would be interesting to see what you're actually seeing in that regard, what the circumstances, what the products were, and whether they were actually insurance products or certain types of self-funded plans, or people who may have. So we want to look at that.
Okay,
issue.
absolutely. The second item that we had, and it's more with insurance payers, is the prior authorization process. As you know, we're doing, when we're seeing a patient, there's lots of procedures and different things that occur. A lot of times we'll see a patient here, and we want to treat them as best as possible and singly while they're here with one visit. So that might mean they come, they present, we need to do a biopsy of sort, but we have to wait and tell the patient, let us call your insurance company so we can verify prior authorization before we do the procedure. And it just becomes a little bit of, it's inconvenient for all, because we want to give that patient the best service that they can. And sometimes they wind up spending more time here just because we're waiting on the phone for an insurance company to tell us yes or no, we can proceed, because the timelines are short to getting those authorizations that we need to proceed with that treatment plan. We find that for same-day procedures, as well as some of our surgical procedures, we find some of the same obstacles. A lot of the insurance companies don't seem to have a consistent policy in place, so everyone has different rules regarding prior authorization. Some want 7 days, some want 10 days, some want 3 days, and the process is very tedious for us to figure out what payers have these different requirements. We try to be as forthcoming and in advance to getting authorizations, but sometimes when an urgent case comes up, we are sometimes bound by these rules where they will not expedite an authorization. So we sometimes have to reschedule appointments or surgeries for patients who really need to have their treatment, and it's inconvenient for the patient. We're delaying their service. So that's the secondary, that authorization process is something else that we seem to really struggle with, because we don't seem to have a good consistency among any payer. Our goal here is, what I was hoping is that we can find that way to build that bridge, that we can, close that gaps in this communication piece between the provider, the payer, and the patient, so that we all are giving that care that we all so desperately want to give to our patients.
No, I appreciate that. And this is really where, these types of programs are just invaluable to us in terms of listening and understanding, where people are seeing problems and issues. And, the idea that, there are times when you're delaying care because of what seems to be a cumbersome pre-authorization process. So we won't be able to explore all those issues here, but part of what we're doing here is, as we get this information, we'll take it aside, we'll follow up with some people, but we'll also reach out to carriers, and and at some point potentially members of the General Assembly to talk about, where there are certain types of barriers, what can we do to help eliminate them or reduce them in ways that make sense for everybody. So I thank you for those insights. They're very, very helpful. And I know that we will certainly be following up with you.
Absolutely. Thank you. I appreciate the time today.
Thank you very much. And then I also, to round out this panel, which I've made go longer because I couldn't follow the directions of my team in terms of what order we were going in, is Emily, and I hope I pronounce this correctly, Luyo?
Yes,
From
Luyo, yes.
Thank you. Who is with the Johns Hopkins Healthcare and as a community health advocate. So welcome, and thank you for being here with us today.
Thank you for the invite. And yes, so I'm a community health advocate for Johns Hopkins Healthcare Priority Partners. So I am out in different communities. There are 8 of us that work throughout the state of Maryland. So many of the things that have been mentioned, I also see as part of barriers for women. I work very closely with the Hispanic population because I am bilingual. And one of the greatest barriers for the Hispanic woman, aside from language, is something that also one of the providers, Dr. Stewart, I believe it was, mentioned, culture-wise, they don't really understand how to use health insurance or how to get health care. Many Latin American countries do not have healthcare like we do here. So when they migrate here, they are not familiar with what is health insurance, how to use it. If they become pregnant, depending on where they live in Maryland, what county they live in, they may have access to resources for prenatal care at a low cost. As well as delivery, and they get help in kind of navigating the system so that once the baby is born, they can apply for health insurance since the baby will be a U.S. citizen. But just navigating through all that can be very difficult. And again, like I said, depending on where they live, depending what county. Some counties don't have resources, rich resources as other counties may have for prenatal care. And then just also, I find that there are a lot of undocumented women who work, but yet they don't have a Social Security, so they're not able to purchase health insurance through the Maryland Health Connection, yet they want to have health care. So those that have perhaps maybe been around for a couple of years with the status of being undocumented, they have learned a little bit about having access to health care, and they want to, they've been educating themselves on the preventive screenings, a mammogram, a pap smear, or perhaps maybe during their pregnancy, they were diagnosed with gestational diabetes, and so they know that they have to follow up, yet they may not have access to a resource, to a qualified health center that they can utilize. And so they want to buy health insurance for themselves, for their maybe significant other, their spouse. They have health care for their children through the Maryland Health Connection, through perhaps maybe medical assistance, but mom and dad are left without any coverage, and they want to buy health insurance, but they're one, because they don't have that Social Security, perhaps maybe they only have their ITIN number, because they are also trying to comply with filing of taxes, but that doesn't allow them to buy a health insurance. And so they're stuck with not having any healthcare coverage. And so as a community health advocate, I am out pre-COVID, I was out in the community providing prevention and wellness workshops. Although I continue to do this in virtual format, And I tried to look up different resources that I can also share with my participants when they attend my workshops. There are still many who it may still be a barrier. So it's very hard to tell women, well, you have to get your mammogram, you have to get your pap smear if they don't have access to healthcare or additional resources, depending on the community that they live in. So I have many families that they are able to get healthcare through the Maryland Health Connection, and that's great because they are able to, with difficulty, because I will share some of the concerns that others have mentioned, that it's not easy to navigate. A lot of the information is not easily understood. And although they may seek assistance going to a health navigator to apply, when they get information in the mail, even though it is available and perhaps maybe in Spanish in this case, it is really confusing when they get the information. It's not clear. I can think of an example. Someone applied for medical assistance. So they went through the whole process and they were assigned to an MCO, but yet they got something in the mail where it said that they got one letter saying that they were eligible for the qualified health plan. And then they got another letter said that they were eligible for medical assistance for the Medicaid. So mom was confused. She's like, what do I have? What insurance do I have? What plan do I have? I'm confused. I don't understand. So maybe revisiting the documentation that gets sent out to the families once they've applied, or the email that they may get. And then, again, with the, all of COVID that's going on, it was harder for many families to get to a navigator to get assistance. Calling to the Maryland Health Connection was also, some people were on hold for a long time. And as an advocate, I was just out there telling them, be patient, when you call, make sure that you have all your documents handy in case you're asked to provide some information. But sometimes for moms, if they have children, they can't be on hold that long, and it does get a little bit difficult for them because they don't know how to navigate a computer, and they don't know how to create their login, or many of them went to a navigator when they first initiated their accounts and they weren't given their username and their password, so they don't have that information anymore. And getting that information through the account by email, unfortunately, again, sometimes they have difficulty doing so. And as an MCO through Priority Partners, I can help our own members. So if they need assistance in reapplying, I can certainly help them with that. But I'm out in the community. I work with, I provide and help anyone in the community regardless of their MCO. So if I were to find someone who perhaps maybe had another MCO, I wouldn't be able to help them with the process. I can only direct them where they can go. So that does also make it hard sometimes being out in the community. But I think for the most part is that I see a great deal in my Hispanic community is that for those that want to purchase a health insurance, but they can't because they lack the Social Security, yet they do have an ITIN number and they are submitting their taxes through that ITIN number, that still isn't something that they're able to use to purchase a health insurance through the Maryland Health
Or the
Connection.
connector, right? And I'm guessing that the connector becomes important because of the subsidies to be able to afford the insurance.
Right, yes.
Now, well, that is very valuable information. I appreciate that. I know that, Michelle, is absolutely looking at the information that's coming across today in terms of, access and understanding the navigator role, et cetera. And I know from our perspective, it's important to hear where these sort of barriers are in terms of understanding. You know, part of Associate Commissioner Hatchett's job is helping to educate folks. So you may see some future outreach from us about, you know, what is the role that we can play, because frankly, you know, we've been quite challenged to find appropriate inroads into the Hispanic community to be able to provide better messaging and what people rely on, you know, for their news. You know, Facebook, for example, you know, more than other media. So we may reach back out to you to help us be more effective in our educational efforts. So, but thank you very much for the time that you've spent with us today. It's been very helpful.
Thank you. And I would be glad to help them whatever I can. Thank you.
I appreciate that. Thanks. And we're going to take you up on that. So let me turn now to the University of Maryland Medical Systems. And I think the focus will be primarily there on the Eastern Shore. And we have with us three folks. We have Kristen Bryce, who is the Senior Vice President and Chief External Affairs Officer. We have Angela Meekins, a social work case manager for care coordination, and Jael Jafari, who is a nurse practitioner. So welcome.
Thank you. Thanks, Commissioner Brain. I hope everyone can hear me okay. Oh, but now there's a phone ringing in the background. I apologize. Really bad timing. My name, again, is Kristen Bryce. I'm Senior Vice President of External Affairs of the University of Maryland Medical System. And I am here mostly to introduce two of our really incredibly talented providers from the Eastern Shore, as you said, Commissioner Brain. But first, I just want to thank you for convening this forum. Is the phone really loud? I can see your face.
No, I'm teasing you. Don't worry about it. It happened to me the other day too. For the nanosecond it started, my phone started ringing and it never rings. So don't worry about it at all.
Who has a home phone anymore?
Our new world, yeah.
Exactly. So I do want to thank you for convening this forum. I think it's really important work, and I think your desire to sort of get ahead of these issues and see them from a consumer and a practitioner perspective is really important. So I appreciate what you and your staff are doing and your commitment. And so just really quickly, you know this obviously, but the University of Maryland Medical System is a regional healthcare system with 13 hospitals and 150 locations across the entire state of Maryland. We have a workforce of over 29,000 people, including more than 4,000 physicians, and we are academically linked to the University of Maryland, Baltimore, that houses the professional campuses of medicine, nursing, social work, pharmacy. I'm missing a few, but our academic presence is also something that defines us across the state. And I just want to make one quick comment, and I don't want to take up a lot of time, but I think you think about the breadth of populations we cover across the state, and just as a comparison, so three of the places that we have hospitals and other ambulatory locations: Prince George's County, Baltimore City, where our flagship University of Maryland Medical Center is located, and Kent County, one of the counties that Angela and Dale both serve. Prince George's County has a population of almost 1 million people. Baltimore City around 600,000 people. Kent County, it's about 20,000 people total. And the 5-county Mid-Shore that is served by the University of Maryland Shore Regional Health has about 175,000 residents total. So again, 5 counties, 175,000 people. And they, as you can imagine, are very spread out. So when you think about density of population, Prince George's County has about 1,788 people per square mile. Baltimore City has 7,671 per square mile. Think about that population density. And then when you talk about practicing in the areas where, again, Dale and Angela practice, Kent County, about 73 individuals per square mile. And that is a lot of territory to cover when you think about transportation challenges and other issues that affect the rural communities in particular. And then one other statistic I'll just share with you, the population. So the over 65 population in Kent County is almost 30% of the population in that county alone. It's about 13% in Baltimore City and Prince George's County. So more than double in Kent County. And I think that the other 4 counties in the Midshore are fairly similar. So I offer that as perspective. And again, I want to let Angela Meakin speak. She's a social work case manager and does care coordination on the shore. One of her assignments is labor and delivery. She works a lot, obviously, with women and also in pediatrics. And Dale Jafari, a nurse practitioner who also holds a Doctor of Nursing degree. And Dr. Jafari practices literally across the entire geography that Shore Regional Health covers and provides care across the entire spectrum of well women's care. So I thank you for the opportunity. Thanks for having us. And I'm really happy that both Angela and Dale are going to have an opportunity to speak to everyone today.
Thank you. Welcome, Angela and Dale.
Hope everybody's doing good. I appreciate the opportunity as well. I was born and raised on the shore, and I'm happy to give back to the community. It's something I'm very proud of. So as she already said, I'm a social work case manager here at Shore Medical Center in Easton. I cover labor and delivery, pediatrics, and our emergency department. But today I'm just going to focus on the children and women's health primarily. So my role, generally speaking, is to link patients to resources that will better their care when they leave the hospital. It could include anything from linkage to mental health and addictions resources to home health services, durable medical equipment, transportation support, supplies for babies, primary care linkage, pediatrician follow-up, and even adoption. So here on the Eastern Shore, we do live in a very rural area. We have a very close connection to our local Department of Social Services and health departments, and I use those contacts frequently for the patients that I encounter. Social Services has family service supports, just like the health department, but they have some different monies that they can tap into, so that's why I like to link patients to both supports. As many know, the family services at Social Services, their main goal is to keep a family unit together. So sometimes they will connect patients and parents more with like parenting support groups and things that are going to help that family stay together and stay cohesive. I tap into the health department most frequently, their Healthy Families program, because they offer mothers and babies prenatal and postpartum services and supports free of charge. It's a really good resource that we use often because it's no cost to those patients. So I like to offer anything I can that's going to better their lives. Due to our local seafood industries and farmland, we have a high percentage of seasonal workers who come to the Eastern Shore for work. And some of those workers travel here during their pregnancies and they deliver their babies at our hospital. Because of their immigration status, as I've heard many other people say, they're only eligible for very limited coverage that usually only includes the labor and the delivery itself. And that's typically under the emergency medical assistance. That doesn't include coverage for prenatal care or postpartum services. And that can cause many issues for a mother if she has any complications prenatally or even during the postpartum phase. I wanted to use an example. I had on labor and delivery just a few weeks ago of a young mom who was here for seasonal work and delivered her baby. And she had a vaginal delivery and had some complications from the epidural. So she had some lingering numbness in her legs, causing her to have some gait instability after she had a baby. Who would think that would even happen after you have a baby? So she couldn't walk. We had physical therapy come and see her. They recommended that she go home with some home health services. So that caused us to have to tap into some different resources because she didn't have any insurance coverage outside of the delivery itself here at the hospital. So locally we have the capability of tapping into some charity care through our hospital's home health agency. We pay for her to have a walker to go home with. And that's just one example of a mom that may need some services when they leave our hospital. There are many times when babies and children in our hospital need home health or equipment when they discharge, whether it's a Pavlik harness, which is used when a baby's born traumatically and has hip dysplasia, or if it's any other type of complex illness that we didn't anticipate. It's, proper insurance coverage is imperative to that child in order for them to ensure they're getting the services they need, and that way they have close follow-up, which in turn, of course, directly affects their overall well-being. Locally here in Easton, we have the Chesapeake Multicultural Center. They're fantastic. I can't say enough good things about them. They help empower people from different cultures to become successful and engaged members of the community. They assist in resource coordination for families who have limited or no insurance. And they even help parents to help keep insurance coverage for their children each year. So they help them reapply for coverage. During the COVID pandemic, I just wanted to mention that our local Department of Social Services and Health Department have done more telehealth visits than ever before, as many people have done. And those telehealth visits have included anything from the addiction mental health services to healthy families visits, parenting supports, and that includes connection to insurance coverage. I just wanted to speak on from my perspective that I haven't seen a major barrier in that time frame during the COVID pandemic. It's rare for me to encounter a minor without proper health insurance coverage in our hospital system. And I just wanted to give kudos to those agencies because I feel like they've done the best they can with the pandemic and the issues that have come up during that pandemic. The last thing I wanted to mention, within our department that we face, whether it's labor delivery, women's health, or even the emergency department, is that we have some insurances, particularly Maryland Medicaid plans that are out of network with our local primary care doctors and specialists and home health agencies. And it's caused a huge barrier in accessing services that patients need, particularly the home health service, infusion, short-term rehab, addiction services, mental health, and equipment. Some of these insurances, they offer single care agreements. However, the local providers and agencies won't accept the single case agreements because they have previously not been properly reimbursed. I'd like to see that issue resolved because it directly impacts care of patients. And a lot of these patients are in circumstances where they didn't know what insurance to choose, and they didn't know what local providers were in network, so they just checked a little box, and then they find out when they finally need the service that they can't get it. And it's really frustrating to not be able to link them to proper services. So I just want to thank everybody for having me on here, and hopefully I didn't go through it too fast, but I was going to let Dale take it away.
Thank you. And just one comment is that, when if you hear a provider say to you that at least an insurance company entered into, sort of a single, case agreement and that didn't get lived out, and we want to hear about that. So we're here. And we're pretty easy, our website, but we want to see that as a complaint so that we can understand what happened there, because we agree we don't want that happening.
Sure. And I can maybe off the webinar, I can send you a list of there's 2 or 3 in particular.
Thank you. Please do.
Okay. Thank you.
Good afternoon, Commissioner Barron, and thank you so much for the opportunity to speak with you in regards to the healthcare we're providing here on the Eastern Shore of Maryland. I am also a native Eastern Shore woman and have been providing care to the women in medically underserved or severely medically underserved communities for the past 42 years between my career as a nurse and then moving forward into my doctoral nurse practitioner role. I see that we've had some significant improvements in care through the Affordable Care Act, where we now have access to annual screening mammography at no cost to the patient, improved access to contraception for our younger women, and expansion of coverage to young adults who are on their parental policies for an extended period of time because they don't qualify for or don't have health insurance on their own. But unfortunately, some barriers remain. The numbers that Kristen provided earlier were pretty staggering even to me, to recognize that we go from 7,000 per square mile to 73 people per square mile, but that certainly is the area in which we practice here. The nurse practitioners or advanced practice providers here at the University of Maryland Shore Medical Group Women's Health are the two who travel to our extended locations. So while we have our core office here in the Easton or Talbot County location, we travel to Queenstown, Chestertown, to Denton, to Cambridge, so that we can be sure that we are extending our care into those areas that don't otherwise have providers on site for access to women's health services. The COVID-19 pandemic has exacerbated some of the pre-existing inequities in healthcare related to access and to racial disparity. Important screening examinations like mammograms and Pap screening were deferred for about a year, and we're just starting to see them beginning to uptick again now. And that's resulting in later diagnoses of breast and cervical abnormalities. Last week alone, I had 2 cases of a high-grade cervical lesion on Pap, and these were people who didn't get their Pap last year and may not have gotten it the year before because of the new screening guidelines that have extended it. But a high-grade lesion is a pretty significant concern for advancement to cervical cancer, and that certainly is the point in which we want to stop the disease progression and intervene. While the screening mammogram or the screening Pap may well be covered under the Affordable Care Act or under the patient's existing healthcare policy, the further evaluation for abnormalities is not always included in that. So the patient that then needs to go onto a diagnostic mammogram or a breast biopsy or further services, or the patient who needs to undergo colposcopy and biopsy or perhaps a LEEP procedure, sometimes are faced with a very shocking bill as they move forward in their healthcare services and find that those services were not included. That presents another barrier to care because they are less likely to come back to either complete that care or to return in the future for a screening where they're afraid that they're going to then receive another huge bill. The services that we engage in here include all women's health services, and we also administer vaccines. Many of the vaccines are also covered thanks to the Affordable Care Act, but unfortunately the HPV vaccine is not a CDC required vaccine yet. So women who may qualify for the vaccine by virtue of the fact that they have not received it and they are age 45 or younger may again be required to pay out of pocket to receive this vital cancer preventing vaccine. Provider access and transportation are as big of an issue for us as has been described by multiple other people. We have patients who live in Rockville, Maryland, who may board the county bus at 6 a.m. to come to their Easton provider appointment at 8 a.m. to be returned to their home in Rockville at 6 p.m. What happens between 8:30 a.m. when their appointment is completed and 6 p.m.? So it's a big issue that's hard for people in more urban areas where you can step outside and the bus stops once an hour or even every half an hour and you get on and you get off as you need to. We just don't have access to that here. Some of the nearest healthcare facilities could be 50 miles from where our patients live. The elderly patient that I had this week who had missed her 3 healthcare appointments. And I thought, that's unusual. You know, I know this lady, I've been seeing her for a long time. I called to find out if there was anything that I could do to assist her, to find out why she was not able to come to her appointment, and was surprised to learn that since she has dementia, she had been transferred into an assisted care facility where her daughter pays $300 per trip from Denton to Easton for her mother to receive her regular visits. So when her mother was already in Easton, because she was now hospitalized for a concern that might have been addressed as an outpatient in an office visit, I suggested don't let them take her immediately back to that facility. Stop by our office. I'll get her in. I'll take care of the women's health needs that need to be addressed. But I also see patients in Denton, and she said, oh, I can get her to your office for less than $15. So it just goes to further emphasize how important it is to provide the services where the patients are and not always need to be centralized in one location where it's a real challenge here on the shore. Telehealth has been valuable and we have utilized it. We utilized it pretty heavily when our regular appointment scheduling was shut down between mid-March and the end of May. But it is not always the be-all end-all that you might think. I used it last week. I was up in the Queenstown location and I had a patient down in Hurlock, which is at the complete opposite end of our coverage area in a small town there, and traveling from Hurlock to Queenstown would have been quite a burden for her. And she had asked me to call her to give her her biopsy results from the breast biopsy last week. I had to tell her that she had a malignancy, and it's kind of hard to do that by telephone. It's a little easier when you can at least do eyeball to eyeball on a telehealth visit. But on the rural Eastern Shore of Maryland, broadband is a huge issue, and not all of our communities have access to broadband. I had my own personal experience with it when we relocated to our new home here in the Easton area, and you think Easton, no problem, they've got broadband coverage. Not so. The broadband ended 3/10 of a mile before our house, and it cost us $7,000 to have the cable run 3/10 of a mile from where it ended to our home so that we could access broadband. Not everybody has access to a nearby or relatively nearby line, and not everybody has access to an additional $7,000 to bring that line to their home. So it's a big problem down here. And I know that's being addressed on a legislative level currently in this legislative session in the hopes that we can improve access, but it's not solving the problem immediately for our patients who can't access the video component. And then that takes you to the reimbursement issues and the issues that are just human issues. It's hard to provide care to somebody that you're not looking in the eye. The last concern that I had to bring forward today relates to equity or parity in reimbursement by insurance and various insurance coverage. It continues to be a significant barrier to care. Advanced practice providers are not reimbursed by all insurers, nor are they reimbursed at the same rate by Medicare as physician providers for providing exactly the same services. Services that may not be available, particularly in our most rural locations where attracting a physician is either impractical or retention is challenging or impossible, are often being provided by advanced practice providers. The issue with the coverage then presents an even greater issue because it costs more money for us to go out into those areas to see those patients, and we are being reimbursed at a lower rate. So our employers are getting a lower reimbursement or RVU than we would be getting if we would see the patients in a central location. That's an issue that I think could be addressed by the MIA and that I would love to see improve over time. I've seen advances in the 20 some years I've practiced as a nurse practitioner, but we're not quite where we need to be yet. Thank you for the opportunity to speak.
No, thank you very much. I appreciate that. And, as with most people, we're going to take this information away and then figure out, and we will follow up. And we may have some consumer education that we do afterwards as well. So thank you very much for your presentation, and from everybody from the University of Maryland Medical Systems, certainly a group that's near and dear to my heart, and I miss being on your board. So take care. Thank you.
We miss you. Thank you.
Thank you, Kristen. Our next panel is our first advocacy group panel, and I'm very excited to have a number of people that are here today. I'd like to, if I may, just jump out of order because there was somebody we made a kind of a promise to about time, and because I'm Italian and I can never shut up, we've run over time. And so I would like this person to be able to go next, and I appreciate everybody's patience in that. So could I invite Lee Binder, who is the Executive Director and Founder of Trans Maryland, to speak to us today about particularly the kind of barriers and experiences that transgendered women experience when they're trying to access healthcare through insurance.
Thank
Lee, are
you
you
so
there?
much.
Oh, yeah.
Thank you so much for having me. It's wonderful to be here today. My name is Lee Blinder, and I'm the Executive Director of Trans Maryland. I use they, them pronouns. And I'd like to wish everyone a happy Transgender Day of Visibility. This is a yearly celebration for the transgender community created by Rachel Crandall in 2010. And I'm really grateful to be here to discuss healthcare for women and their dependents, and as well some of the nuances of where that overlaps for the transgender community. I'll tell you a little bit about myself. I'm a non-binary trans person, and what that means is that I'm not the gender assignment I received at birth. I'm also neither a man or a woman, but instead I'm a third plus gender person, a person outside of the gender binary. My legal gender and sex marker in the state of Maryland is X. And Trans Maryland serves trans people all over the state. We are a multi-gender, multiracial organization. Our services include a name and gender marker change program where we assist trans people with the process of legal name change by easing, and also gender marker change, by easing financial and logistical barriers and providing peer support and linkage to care. We also offer a weekly digital support group for Trans Marylanders online and have done so throughout the COVID-19 pandemic. We convene a separate digital space, peer space, for almost 1,000 Trans Marylanders to connect and crowdsource information about safer mental health providers, primary care providers, and specialists such as surgeons. There are many questions about healthcare, everything from someone who needs to onboard into care and sign up for healthcare and pick an appropriate MCO, to where to get a haircut without bigotry and how to come out to family and coworkers. These insurance conversations are really complicated as some MCOs do not provide coverage for all gender affirming care that's needed by the trans community. So there's a disparity of care depending on where someone lives and what access to which MCO they choose. Maryland is behind states and jurisdictions such as DC, California, Connecticut, and Minnesota, to name a few, in terms of what is covered by state Medicaid plans for gender affirming care. The procedures that Maryland erroneously deems cosmetic are documented as medically necessary and life-saving by MDs, surgeons, mental health providers, as well as the legal system. The exclusions through Maryland Medicaid of facial gender affirming surgery, gender affirming hair removal or transplants, and vocal therapy or surgery, just to name a few, are also in violation of federal law. Transgender women and trans feminine people and women who have transgender dependents often struggle to access affirming healthcare across the state of Maryland. What this means in practice is that we have a massive care gap for the transgender community. Many trans people who are not women need to access services that are often viewed as services for exclusively cisgender women. And cisgender means that someone identifies with the gender assignment they received at birth. Some trans men and non-binary people need to access pap smears or mammograms. Some trans women and trans feminine people need to access prostate exams or other care that many insurers reject for a gender marker mismatch, unless the office knows how to implement the proper ICD codes to avoid this. There are many opportunities to improve accessibility for trans people in Maryland, and I employ administrators and other decision makers to invest in paid trans-led training and consulting for your organizations. This has the dual benefit of improving care for patients, as well as can be crucial towards achieving a gender diverse staff and retaining your transgender staff members. Trans people really rely on having an affirming care environment, and onboarding into care can be a very challenging experience for the trans community. What we see is patients and trans people who are seeking care, and unfortunately, they're not receiving a positive experience. And when this happens, what the end result is that they end up avoiding care or falling out of care. And so we have this significant opportunity to take back and really to implement just a few simple things in order to be rising to the level of an affirming care provider. This comes up through electronic health records, as well as the training for frontline staff, in addition to the medical teams. Everyone has a body and needs to have care for it, and every transgender person deserves to receive affirming care for their body. We have parents who are cisgender themselves and have a transgender child, and they come to us asking, where to bring their child for affirming care, where it's going to be safe for their child to feel affirmed, to have their correct pronouns used, and to have their appropriate name used during an appointment. All of these things are really simple solutions to be able to affirm your trans clients as well as your staff. And that's all from me. You can find out more about Trans Maryland on Facebook at facebook.com/transmaryland, or also on our website at transmaryland.org. Thank you so much.
Thank you very much. I feel like there was such a wealth of information there. I know that we will reach back out to you, at least at the Maryland Insurance Administration, to perhaps continue this conversation. You mentioned things particularly about Medicaid, but do you encounter the same issues with regard to private insurance? I would expect that you do.
Yes, absolutely. I know California particularly has a law for requiring trans care to be covered in private insurance as well as through state plans. Maryland only has that law for state plans.
Well, I want to thank you. We will be having some other listening sessions that are, more specific, but I wanted to make sure that in our engagement today, that we did not leave anybody, and literally anybody, out of the equation. So I really appreciate the fact that you were willing to come and speak to us today. And I'd like to invite you and perhaps some providers as well to a separate conversation. And I particularly would ask you for your assistance we just want to always get it right. We want to get the substance right, but we also want to get the vocabulary right. And I know that sometimes that's awkward for people, it can be awkward for me. And I want to make sure that my team is as knowledgeable and as educated and as affirming and welcoming as we can be. So I'm going to take you up on the offer to learn more and invite you in to help us be better able to help all citizens, all Marylanders, whether they're citizens or not. So
Wonderful. Thank you. I look forward to it.
thank you. Take care. And thanks for joining us.
Thank you so much for having me.
So I'm going to introduce now Dominic Goodall, who is a project coordinator, and Chelsea Gleason, who's a bilingual child and family therapist, both with the House of Ruth. Thank you both so much for being with us today as we are exploring issues about, insurance, how people use insurance and women, their dependents in particular, in accessing healthcare and what some of those barriers are.
Thank you so much for having us. My name's Chelsea. Dominic is not on the panel, but Jocelyn, who's from the Training Institute, is watching from the audience. So they're from our Training Institute from House of Ruth, Maryland. But thank you so much. This has been wonderful. My name is Chelsea Gleason. I am a bilingual child and family therapist and have been for the past 2 years at House of Ruth, Maryland. A little about House of Ruth: we lead the fight to end violence against women and their children, and we focus on intimate partner violence. Our vision is that one day every woman in Maryland will be safe in her own home. We put women in our vision statement because we recognize that intimate partner violence or domestic violence disproportionately affects women. So that means in my job, I'm mostly working with women and their children. House of Ruth, Maryland has several different offices representing different populations. So today I'm going to speak about the population I specifically work with, even though we work with different ones. I work in the Highlandtown office, so all of my clients are immigrant women and children, almost all. We do serve people of other genders, transgender men, but primarily I'm working with adult survivors and their children who have witnessed intimate partner violence. So speaking from that perspective, the large majority of my clients, when I'm trying to provide mental health services, are undocumented, Spanish speaking, and they don't have much access to services. And that includes children who are undocumented, who I might see for therapy. And I think the biggest issue is just, especially for those undocumented clients, having no way to access health insurance, and having to rely on free and low cost clinics, which there aren't enough to fit the capacity of the undocumented community. So even as someone's trying to get status, say, trying to get a U visa or trying to get VAWA, they might be barred from government services. So they can't for their actual application seek services. So that's another issue. So what I see is that a lot of my clients can't get their medical needs met, or they face exorbitant bills if they try. And then they often delay medical or mental health services until it's so bad that it's an emergency or a crisis. And then they're facing a really big bill and they're afraid to go to the hospital, or they're afraid if they need to call for an ambulance because those bills are really, really high. I've also seen with COVID, and this has been touched on by some other advocates, which I think was important, that there's a lack of knowledge about if you can get a vaccine, if you can get tested if you're undocumented, which you can, but people are afraid. They're afraid that if they give their information, it'll get to ICE, they'll be, maybe they'll be deported or something like that. So there's also this sense of mistrust and fear, like, is this vaccine safe? I don't really know anything about it. No one's talked to me about it. So House of Ruth, in my position as therapy, we're one of the few agencies that provides cost-free therapy without insurance. No one has to show us their insurance. We're grant funded, which is great, but it has its limits because based on our grant funding and our capacity, can only provide short-term therapy. And because there aren't many bilingual mental health providers, after our 8 to 12 sessions, if a client still needs therapy, and we're providing trauma-informed therapy, culturally sensitive services specific to intimate partner violence, if they want long-term therapy, we don't really have many places we can refer them to that don't require insurance. Similarly, if a client needs medication management or psychiatric services, they're going to face a lot of barriers if they don't have insurance. And even if they're in a mental health crisis, like last week, I had a 17-year-old who's undocumented, uninsured, and I needed to send her to the hospital for suicidal ideation and a plan, but she doesn't have insurance. So it was a huge fear for her going. Thankfully, the hospital was helpful in trying to help get her charity. But that's not a guarantee either. And there's a lot of fear around that. Also, survivors of IPV face physical injuries. They might be choked, kicked, hit physically, and sexually abused. And it can be helpful if that person can go to the doctor and get a report, especially if they're going to press charges or have a case, but they may be fearful because of lack of insurance. And then even if someone does have insurance, there's the language barrier, which people have really touched on in this panel. Clinics are supposed to have interpretation. They're supposed to, at bare minimum, have language line, but a lot of times they don't, or they don't know how to use it. And there's no replacement for an actual bilingual staff who can talk face to face. And then I've also had clients complain of what they feel is inhumane treatment, being discriminated against or neglected even. I had a client recently who got treatment at the hospital. She had to get her uterus removed because she was infected by her abuser. And that doctor she started having complications and she couldn't get through to the doctor. She went to the emergency room. People weren't helping her to follow up and she was really in a crisis. So she had to switch doctors, and we're talking about doing a medical complaint, but that's something that's unfamiliar to a lot of people too. So in summary, my recommendations, given all of that, is I feel that there should be more funding and maintenance of accessible, no and low cost or sliding scale medical and mental health clinics, fully capable of providing both interpretation services for Spanish and other non-English speakers, and multilingual staff who can assist clients. Direct multilingual outreach to immigrant families focused on providing public health information, safety information, education on the right to access care, means for communicating any discrimination that may occur, and accountability measures if a discrimination occurs. Trainings, cultural competency, and sensitivity for healthcare providers tailored to the unique needs and experience of immigrant families. So people understand where people are coming from and why they might have mistrust and why they may see healthcare differently based on their country of origin. And then training, hiring, and supporting immigrants in reaching out to their own communities with public health information, full involvement of immigrant families in shaping insurance and healthcare policies that impact their lives, because a lot of my clients are eager to be advocates as well. So in conclusion, the ultimate solution is that we need to give insurance to undocumented people. But in the meanwhile, these recommendations could be really, really helpful in giving people access to care that they need. So
No, I appreciate that. And I'm sure the Maryland Department of Health, in particular is happy for the information as well. I know that they're much closer to these issues, obviously, than the Maryland Insurance Administration is. But I thank you very much for your time and your perspective.
Thank you so much.
And I'm now going to invite Michelle Doherty Siri, who is the Executive Director of the Women's Law Center. Happy to see you with us today.
Thank you so much for having me. I'm Michelle Siri. I'm the Executive Director of the Women's Law Center of Maryland. And unlike most of the organizations that you've heard from today, we do not have any providers. I am not a provider. We are instead a nonprofit law firm, and we represent survivors of intimate partner violence, sexual assault, and human trafficking in protective order hearings, in family law matters, and in immigration proceedings. We also have hotlines from across the state for folks calling across the state in employment law and family law matters. And so I'm coming with a slightly different perspective about when folks are really trying to figure out what their options are, whether they want to leave their abusers when they're in the midst of a family law situation, and the role and impact that insurance or the lack thereof might play in their lives and in their considerations. So the first thing I want to touch on is privacy. And, a law was passed a few years ago that allowed patients to shield certain information on their explanation of benefits. And that was really important for survivors of intimate partner violence because many of them didn't want their abusers or partners who were the ones holding the primary beneficiaries of the insurance to know if they were seeking counseling, if they were seeking medical treatment for their abuse, or if they were on birth control pills or antidepressants. Those are all things that can be very triggering in an abusive relationship. And so that ability to have privacy is so important. But what we have found is none of our clients, when they come to us, are aware of that. And I know there were efforts taken to try and get that information out, but it's just not trickling down, or at the very least, it's something that maybe when folks are signing up for insurance, they're being told about, but when they are in need of this actual privacy, it comes up later on, and that's just not something that they're thinking about. So we're realizing that really none of our clients are aware of that. So we do try and explain it to them, and they do find it helpful to know. And similar to that is simply that the idea of being able to access their insurance information. As I'm sure Chelsea could understand, we talk about making sure they have copies of their insurance cards with them and ready to go in case they have to leave in an emergency. And so there are challenges that we find a lot of times with when if they have to leave and they don't have their insurance cards or their children's insurance cards. They are denied benefits sometimes, or as Chelsea was saying, they're afraid to go and seek services for themselves or their children because of that. And then the third thing that I wanted to talk about, and again, we're not providers, so it actually took a lot of digging for me to try and exactly figure it out, but it's the idea of the open enrollment. And under the ACA, it's my understanding that domestic violence is a triggering event for a special enrollment period, but that it's not in Maryland. And it's something that, again, is a consideration for women, especially women with young children, because the finances are always going to be one of the reasons that they consider leaving or staying. And insurance is obviously going to be a big part of that consideration and that the calculations as well. And so it's just something that we've been talking about in the office, trying to figure out how we can gain, economic security is really one of the biggest goals for our organization. And so trying to figure out those factors for our clients while we're navigating the legal system for them.
That's very helpful. You've given me a couple of things to think about and to follow up with you on. So, the Women's Law Center, is great. I've just recently out of DLA Piper. I know Ellen Du, and
of course.
So, thank you for being with us today. I really appreciate it.
And thank you again. I know we're not the typical what you're hearing, and we don't have exactly that expertise, but I appreciate that you wanted to listen to the perspective that we had.
Yeah, and people come to you with problems, and what's most important is that for us, for the Maryland Department of Health people are here, and for Michelle and the connector folks that are here, is that we don't get to hear everything, and these are opportunities for us to hear. We may not be able to fix it, like out of our current law or our current situation, but maybe we can. And if we can't, maybe we have the ability to go to people who can change it and at least start a conversation. So thank you very much.
Appreciate it. Thank you.
Take care. And now if we could hear from Dr. Geddes, Ann Geddes at the Maryland Coalition of Family, the Director of Public Policy there. Thanks for agreeing to be with us today.
Yes, thank you, Commissioner Brain. Can you hear me?
Yeah.
You can. Okay, thank you for the invitation to speak today. Again, my name is Ann Geddes. I'm the Director of Public Policy with the Maryland Coalition of Families. MCF provides family peer support and navigation services to families that care for a child with mental health needs, or to any loved one who cares for somebody with a substance use problem. The majority of those are parents of children, adult children or adults with mental health, with substance use problems. And today I was going to address the topic of mothers trying to access behavioral health care for their child, adolescent, or young adult. I want to just start out by saying the responsibility for this falls on mothers. We, 94% of the families who contact us, it's the mother who's contacting us, not the father. So when a family is struggling to access care, it is often the mother who is the one who's advocating for the child. The number one reason families contact us is for help accessing behavioral health treatment for their child. And I think it's important to note that by the time families find us, by the time they land they make that phone call, they've had struggles. They've encountered barriers, and that's why they're reaching out. And I think there were three main areas that I wanted to touch on today. One is the difficulty families have finding an in-network child and adolescent provider for behavioral health. There is a shortage of child and adolescent providers, and a lot of times families don't feel like they have choice. There may be one in their area, one child and adolescent psychiatrist in their area, which is a large area, who provides services. There are even therapists that specialize in working with children and adolescents. They are limited number. That can be hard to find. Some provider directories do not list that's a specialty. So you can have trouble finding a provider, and there's a limited number. And those that have good reputations often have long waiting lists, aren't taking new patients. So there's a lot of struggles to find a provider, psychiatrist or therapist who's good at working with children. The second major barrier is the array of services through private insurance is not available to families as in Maryland that Maryland Medicaid provides. Families are aware of this, either from hearing from friends or from going to a local care team meeting or a variety of places. If you receive services through Maryland Medicaid, a child is eligible for psychiatric rehabilitation program services, PRPs, targeted case management services, respite services, and intensive in-home services. None of those are available to families with private insurance. So some of the time we spend working with families is trying to see if there is some way we can get the child on Medicaid so that they can access these services. And that kind of segues into the next problem, which is families have is difficulty accessing residential treatment for both mental health and substance use. For youth with mental health needs, residential treatment often is not a covered service. And if it is covered, it's for a very limited number of days. Often frequent reauthorizations are required, like every 3 days. In Maryland, the residential treatment centers typically average length of stay is 6 to 9 months. Maryland Medicaid pays for that as long as it's deemed medically necessary. So what families with private insurance do is try to get if their child is in need of residential mental health treatment, they get their child eligible for Maryland Medicaid by this process, which is called a voluntary placement agreement, which is a cumbersome and really difficult process, whereby the child, after they enter a residential treatment center, they become eligible for Medicaid 30 days retroactive as a family of one. And the processes of doing that are really a challenge, and it's not good for families. It's really a burden. And then for adolescents and young adults with substance use needs, substance use residential treatment typically is a covered service under private insurance, but it's a very limited benefit. Again, authorization for just a few days at a time, 3 days, maybe continual reauthorizations are required. A maximum of 28 days if you're lucky, 14 days may be more common. And, you know, this is just my, one of my real things that upsets me is that you hear that residential treatment, substance use treatment doesn't work for adolescents, that it's not a evidence-based practice. It may not be evidence-based, but the way we practice residential treatment for adolescents with substance use problems is we will give them 14 days of inpatient treatment and then send them home, and they fail, and we say it doesn't work. Whereas for adults right now under Maryland Medicaid, you have 2 30-day stays in a 1-year period, after which you go into a recovery house for 6 to 12 months. Recovery homes are not options for children and adolescents. There's no such thing. So we anticipate that an adult will need maybe 12, 14 months of sustained treatment, residential treatment, but we expect a child to respond in 14 days. That just is kind of boggling to me. And there is a need, there's a tremendous need for substance use residential treatment in Maryland. Also, you know, adults, they have similar, young adults with substance use problems have similar barriers. And we hear stories of families who have the resources, remortgaging their homes or drawing on their retirement to send their child, either adolescent or young adult child, to residential treatment because it's not a covered service, and they feel desperate that this is the help their child needs. So, you know, $50,000, $60,000, $70,000 price tag for them to have their child enter treatment. So those are the main points I wanted to make.
No, I hear you, and I appreciate the parity concerns and considerations. Thank you for spending this time with us today. My staff is yelling at me because I'm not managing time well. So I could spend a lot of time with you on this topic, and we have had other conversations and other, you know, forums on this, and we will continue to do so. So thank you very much for today. And let me turn now to Lisa Skipper, who is the Insurance Enrollment Navigator at MHBE for the Mountain Laurel Medical Center. And I'm very happy to hear from you today with respect to some of your experiences in insurance and access to healthcare and what you're finding. You're on mute. There you go.
Can you hear me now?
Yes.
Thank you again for having me. My name is Lisa Skipper, and I'm an insurance navigator with the Maryland Health Connection. I work at Mountain Laurel Medical Center, which is a community health center in Garrett County. And we see patients regardless of ability to pay. We offer a slide program for those who qualify based on household size and income, much like the marketplace, but it's only available for services at our offices. If they're eligible for this slide, then they may be eligible for Medicaid or insurance through the marketplace, which I can assist them with. And many of the people that I assist do not have access to internet or computer skills, so that's why they rely on us for assistance. I've assisted our patients and anyone in the community without insurance since the Affordable Care Act began. When I first started in this capacity, price was the biggest barrier. Because contrary to belief, many multiple carriers in the marketplace make higher premiums. But since that time, for the past 3 to 4 years, we've only had Care First in this area, and premiums are much lower. For example, a consumer making $55,000 with a yearly income, and or a couple making $55,000, sorry. With 2 children, they can enroll in a Care First HMO Gold plan for $4.84 a month, versus the PPO Gold plan that would cost them over $400 each month. Now, those prices are going to probably change a little bit tomorrow after the American Rescue Plan Act changes the rates, so we're looking forward to that. But because we live in the far west region of the state, Morgantown, West Virginia is our preferred location for specialty care. So while Garrett County has multiple primary care provider offices, we have very few specialists in the area and patients are referred elsewhere. So lack of specialists would be our second, and actually now I think it's our most important barrier. We have quite a few women who go out of the area for OBGYN, and for high-risk pregnancies, they tend to travel to Morgantown, as well as those for oncologists. For someone enrolled in an HMO plan, they have to remain in the state of Maryland. So they would go to Cumberland, Maryland, which is about the same distance as Morgantown, about 45 minutes, or they would head further east, which would be University of Maryland or Johns Hopkins. Enrolling in one of the PPO plans allows them to seek specialty care in Morgantown, or in some cases, people would prefer going to Pittsburgh as opposed to going to Baltimore. You're probably looking at about an hour's difference. So I think sometimes that or familiarity. And I know that Morgantown is easier to navigate. So that's, and then the idea that it's only 45 minutes. So for back and forth treatments, it's definitely a lot easier for them. Probably about a third of the people that I assist with insurance enrollment do not currently have any health issues where they see a specialist, but they will enroll in a PPO plan so they have the ability to go to Morgantown if something changes. If the HMO plans were accepted in Morgantown, I think most would enroll in the plans instead of higher premium PPOs. On the private insurance side, referrals to see behavioral health specialists, especially United Healthcare, and we're seeing this in our facility. They take a long time for referrals, and many times they have to require a lot of follow-ups to try to get them corrected. Our community health workers see barriers that low-income housing or housing for homeless is limited in our area, and the waiting list is very extensive, and then sometimes it's even been for several years. Another barrier is the same as what a lot of others have said: transportation to appointments. For some patients that we have that travel to Johns Hopkins or WVU, they have a hard time getting there. The community health center where I work, we give gas cards to our patients in some instances so that they can go to those appointments. And then another program in the county is through Garrett Transit Service, which they offer some transportation, but unfortunately they don't apply in every situation. Our local hospital is affiliated with WVU, so they're more likely to refer everyone to Morgantown than to anywhere else. And unfortunately, going to Garrett doesn't guarantee that the HMO plan would be covered completely, because I've had a couple instances where patients have had lab work there, and then because they don't have pathology at the Oakland hospital, they send it to WVU to be read, and then the patient gets a bill for over $500. And while Garrett County has a lot of services offered to women and children through our Garrett County Health Department, such as the WIC and breast and cervical cancer programs, Garrett Community Action has housing and transportation. Department of Social Service has food stamp assistance, but there is still a need for better access to specialists. So that would be our main barriers, I would say. And again, I thank you for the time on this forum.
No, I really appreciate that. And that is important to know. With regard to specialty care in particular, with regard to network adequacy. So thank you for that. Something we're very actively engaged in looking at right now. So very timely. Thank you.
Thank you.
And I am going to move on now to Nicole Warren, who is with the Maryland Maternal Health Innovation Program. I believe you're an associate professor with that program. Did I get that right?
Yes, you did. Yes, you did. Thanks for having me, and I'll try and keep my comments brief. I know it's been a long but informative call. So first, thank you, Commissioner, and of course the organizers for having me. I'm excited to represent MD Mom here, and great to hear from all my colleagues on this call. It's amazing work that is being done. I am, as I said, here to represent MD Mom and tell you a bit about our program. And I think that some of what we're doing really complements and supports a lot of the efforts that you have described today. And if I say anything that prompts some questions that I can't answer, I can absolutely find a colleague on my team who can do that for me. So what is MD Mom? It is a 5-year program to improve maternal health in Maryland. The funds were awarded at the end of 2019, but it really feels like we're getting going in earnest right now because we've just spent this time laying the groundwork and creating the infrastructure. MD Mom is a collaboration between Johns Hopkins, Maryland Department of Health, Maryland Patient Safety Center, and the University of Maryland, Baltimore County. It is funded by HRSA. So I'm just going to walk you through the two main sort of workflows of MD Mom. So the first is to improve maternal health data availability and utilization, sort of the outcome, the downstream effect of all the kinds of conditions you've been talking about certainly relate to what the work that we're doing. The other big category are innovations in maternal health service delivery. So first, I'm going to talk a little bit about that first piece, which is maternal health data availability and utilization. So the first part of that is really focused on severe maternal morbidity surveillance and review. Very few states have this. Most states have mortality, but not morbidity surveillance and review. So this is going to be initiated in 6 hospitals, and they will pilot the program, and there should be a pilot evaluation in this summer. And that will be set to scale up all the way through 2024. These data are critical because, as many of you know, many more people experience morbidities than mortalities. And so we can get a lot of rich data by following these outcomes and getting a better look at disparities and contributing factors. And the second part of improving access to and use of maternal health data is what we're calling the maternal health data dashboard. This will include both outcome data, things like maternal mortality, severe morbidity, but also sociodemographic factors that often are not always connected. So the dashboard will help do that for us. And that'll be available through the MD Mom website, which I want to encourage everybody to visit because it's a great resource. And now I'm going to move on to the second major work stream, which is the innovations and health service delivery. So the first innovation I'm going to talk about is the place where I spend most of my time, and that is what we call the hospital initiative. A lot of folks on this call have talked about the needs that patients have in terms of education and knowledge and health literacy. Well, the hospital initiative is really provider facility facing, and it's really a group of quality improvement activities. I want to highlight a few of them. Those include online trainings around implicit bias. So there is a didactic component followed by skill building sessions. We can't just learn about our bias and learn what they do, but then also build skills to try and mitigate their effect on our care. We also will have some education offerings related to learning from adverse maternal events in Maryland that come from Maryland case studies. And the third educational piece is focused around managing bias in the care of patients with substance use disorder. We are working hard to partner with all 32 hospitals, all 32 birthing hospitals, and we already are very much in full swing with 8, with the other 24 coming right behind. So those online trainings will be followed by, as I said, with skill building sessions. And then following that, we're going to be partnering with hospitals to help implement an equity and safety toolkit, which will really meet the hospitals where they are and help them advance their efforts to achieve equity. So these, the other innovation that might be of interest to this group is our obstetric telemedicine network. The program director, Dr. Andrea Kranga, is really the leader of this piece, and following a landscape analysis on this topic that they conducted last year, they're now in the middle of designing essentially the way to develop the program plan, how to establish agreements with pilot sites that are going to be partnering with level 1 and 2 hospitals, as well as federally qualified health centers, and then getting our team, which involves both Hopkins and University of Maryland, coordinated. And the goal is to start that telemedicine by September 2021. Excuse me for the ringing in the background. Of course, that doesn't happen until I'm speaking. Okay, another important innovation as I wrap up here is our collaboration with home visiting centers around maternal warning signs education. So this really does bridge that connection between patient health literacy and contacting your provider. And so MD Mom is partnering, as I said, with home visiting agencies and working with their on the ground patient facing home visitors to help disseminate important maternal warning sign literature and information in a very systematic, comprehensive way. And finally, there are a few other things that, seminars, webinars, there are resources for hospitals, for patients on our website. And I think I'll just stop there. I would argue that our program is very much complementary and supportive to many of the issues you all have spoken about today. And I'll stop there in case there are any questions. Of course, all of this is being rigorously evaluated, but I think that's beyond the scope of what this group wants to hear. So thank you.
No, I appreciate that. And we'll probably invite you to come back to when we get to the role of insurance in addressing health inequities. And probably talk offline about telehealth as well, because obviously telehealth is an important component when it's appropriately deployed. And, it's not the be all and the end all, because it doesn't work in every jurisdiction and every zip code, but there's tremendous potential there. And so I know we would be interested in hearing more about that as we think about, as the administration, how telehealth fits into the bigger picture of network adequacy. So thank you very much for your comments today, and we'll talk more. So let me move on to Mr. And I want to make sure I pronounce this appropriately, Del Pozo.
That's right.
Did I get that right?
Yes.
Thank you. Who is with the Latino Health Initiative. So again, thank you very much for being here. Thank you for being patient while, my chachara myself just kept going with questions. And I know we're a little bit behind the time that we thought we would get to you. But if you would share with us your thoughts about the role that insurance can play in terms of access, some of the barriers that you experience and the concerns that you have where the gaps are.
Sure. Thanks so much for having us again. My name is David Del Pozo. I work with the Latino Health Initiative. I'm joined today, hopefully, by my colleague, Rosa Guzman, who is hopefully going to be able to add her insights in just a moment here. We're part of the Department of Health and Human Services in Montgomery County, and we have years of experience to, reaching out and providing community education and outreach to the Latino community of Montgomery County. Obviously, in terms of barriers, I don't want to spend too much time repeating what many of our colleagues here today have already mentioned. A lot of the things that are kind of most on my mind these days is really tinged with the experience of this past year living through the pandemic. And so things like forms and everything sort of moving to online forms, transportation, and now the bus isn't running because they've cut back on those hours due to the pandemic and all the different impacts of that. One of the sort of new areas of concern that we've had to address is combating myths and disinformation that transpires online and social media, and also just interpersonally from one person to the next in terms of what a shot might do, what a test is like, does it hurt, does it cost money, those kinds of things. In terms of just sort of like one of the common denominators here, though, I think that one of the real big important issues has to do with trust. And it's not just like translating documents into Spanish and being able to demonstrate, oh yes, we have something in Spanish for this community as well, but rather, who are the agents of trust who are forging those connections with people on the ground and in hardly reached communities that can then deliver that information. You might have a wonderful flyer, you might have an amazing program, but if you don't have somebody who is sort of an agent, a reliable, trusted agent to connect that resource with that community member, then it's going to go untapped. These are sort of phenomenons that we've seen for a long time, but obviously the pandemic has exacerbated their impact. Some of my colleagues earlier mentioned the issue of sort of health literacy, and I think that is a very valid point. We're talking about folks who have recently arrived in this country, who have not grown up here and have not experienced healthcare in the way that many of us have. And so something like preventative care may simply be seen as like a luxury item and not something that is something that I need to worry about. Maybe it's a little bit different for my child now that they're born, now that they're young and need all the support that they can get. But as far as me taking care of myself, taking care of my spouse, that might be a totally different story. I think that in the communities that we serve, there is a strong connection, and some of the colleagues earlier mentioned also that there is a willingness to access services and insurance and all these types of things. But if we could leverage sort of informal communication networks better, I think that could be a really fruitful way of engaging people. In terms of in the last half year or so, one of the things that we've done here in Montgomery County is utilizing WhatsApp chat groups and social media, and doing just a ton of outreach to engage the communities that we're trying to serve. I was talking to a provider recently, and they mentioned that they had seen an 80% reduction in children who had been enrolled or registered for the child health insurance program here that we have in the county. And it's because the schools were closed. So like if the school is a primary partner or conduit for those registrations to take place so people can get access, and now the school is closed, well, that's a monumental barrier, right? That's unexpected and that's unprecedented. But what does that say about our systems that, and again, a pandemic is really an unprecedented event, but how can we adapt in the face of, mass cancellation of in-person learning, moving to virtual? How are health systems, how are the forms that we post and provide to the clinics and that we require face-to-face registrations for, how are those things being adapted to mirror the reality that we're living in? And so just in terms of a final comment here, one of the things that we've had success with over the last almost year in doing a lot of the COVID-related community outreach work we've done is working with community partners who are allowing us to achieve sort of that deep penetration within the community. That means church groups, early education centers, residential complex managers. There's kind of no wrong answer when it comes to who can we work with, who has a direct connection of trust with the community. That's who we need to work with. And then just finally, just to say, sort of, we talk about barriers, and I think that there is sort of the implication that the barriers is on the recipient, on the consumer. Maybe we can think about it as like the barrier is ours. What are the things that we can do to reduce our barrier to be able to connect to the community out there? So with that, I will pass it over to my colleague, hopefully. Rosita, are you there?
We may not have had her on the panel because I just had your name as the person. So other people who tuned in may not have speaking ability. But let's see, maybe at the end we can come back.
I see her.
Commissioner,
yeah.
This is Joy. She has been added, and so she should be able to speak.
She just recently dropped off. She was on there as a panelist, but she just recently dropped off.
Ma'am, we can come back if she comes back on. I wanted to jump. So thank you very much for those comments. And I particularly like your insight at the end of who's got the barrier. At the end of yeah.
Hi, this is Rosa.
Hi.
So I know someone is gonna translate for me.
Yes, good afternoon, everyone. Commissioner Ryan, this is Guadalupe. With the Maryland Insurance Administration, the Consumer Education and Advocacy Unit. I'll be interpreting for Ms. Rosa Guzman. She's a community health promoter with the Latino Health Initiative.
That's great. Well, we'll be very happy to hear some brief remarks. Thank you.
Sí, buenas tardes. Ya me introdució, soy promotora. Sobre las barreras que nuestra comunidad enfrenta son varias. La primera es el idioma. La mayoría de nuestra comunidad no habla inglés y por ese motivo les cuesta más tener información. Tienen que esperar más tiempo para que les ayuden marcar y poder usar la línea bilingüe. Pero hasta ahí, para que traduzca.
Okay, gracias. Ms. Guzman stated that one of the big barriers is language. A lot of the Hispanic community do not speak English, and most of the time when we do have to make phone calls to other places, we have to wait for a longer time, either for someone that speaks Spanish, a representative, or language assistance. Puede continuar.
La mayoría no tienen, tienen problemas, a veces no saben cómo leer ni escribir su propio idioma. Estas personas necesitan ayuda para llenar su aplicación.
A lot of community also have problems with writing and reading their own language. So that's another big problem that our community has as well.
Y sobre la tecnología, nuestra comunidad no cuenta con una computadora y no pueden pagar el servicio de internet. Más complicado, no saben cómo usarla.
Also, lack of technology. We don't have devices like computers, or sometimes we have to pay for access to the internet in order to get health services or healthcare insurance.
El transporte es otro problema. Una familia recién venida de sus países no conocen, dependen de un esposo o un familiar para que les lleven a las citas. Si van en bus es difícil, con los niños tienen que comprar una tarjeta. Son familias de bajos recursos que no cuentan a veces con un vehículo propio.
Another problem will be transportation. A lot of our families who just recently arrived from other countries, we have to depend on others to receive transportation because we just arrived. We don't have a lot of knowledge of services or even the assistance of the money to get a vehicle.
Cada año se hace el enrolamiento de Maryland Health Connection. Tienen un código que se usa para poder entrar en sus datos de cada familia registrada. Siempre se les olvida. Al siguiente año ellos van y se les pregunta por el código o lo dejaron en la casa o ya se les olvidó. También en los comprobantes que les piden que un empleador les dé una carta. A veces el empleador no se las quiere hacer. Tienen problemas porque dicen no va a perder el empleador un día por ir a notarizar una carta para darles porque no cuentan con colillas de cheque o una W2 o el documento que el Maryland Health Connection quiere, que es la 2014 o la 1099.
Okay. And when it comes to enrolling into health insurance through the Maryland Health Connection, a lot of our community forget our credentials to log into the application, and we don't have access to the application. So a lot of the time, that's why we end up not enrolling. Also, when it comes to the employers, we have to provide proof of income to the Maryland Health Connection, and some employers do not even want to write a letter for us, so we can be able to provide that documentation since we can't receive like a pay stub. Puede continuar si tiene algo más.
Ok, sí. Respecto al mismo Maryland Health Connection, tienen muchos problemas en entender porque tienen que pagar un copago y además un deductible. A veces el deductible dicen es de, por ejemplo, $500. Hasta que paguen esos $500, pueden solamente tener la mensualidad. Entonces hay personas que dicen, si tenemos que pagar un deductible, un copayment, más la mensualidad, tenemos que elegir a veces o ir al doctor o pagar la renta, porque se les hace mucho. No sé si ellos pueden como hacer un solo, que les quede un solo pago, no el deductible, sino un solo pago mensual y el copayment, como las aseguranzas privadas.
Also, when it comes to the Maryland Health Connection plans, they learned that there's a copay and a deductible and all these different terms. When they hear the amount of the deductibles that they are too high, there are some people who said we either pay our rent or we go to the doctor. It's just too many things to pay, copays, deductibles, and even the monthly premium. So they have to decide whether they either have to pay their rent or go and pay for this insurance in order to go see a doctor. It will be good if maybe it will be one single type of payment. I believe it will be easier for our community to continue paying for their health insurance.
Let me stop for just 1 second here and just assure everyone that we are not stopping at 4 o'clock. So I apologize that, but it's so important for people to have the opportunity to speak and to be heard. And not everybody gets this opportunity all that much. And so I deeply apologize to folks who have been, an hour behind the time when we said we would get to you. But I'm here to hear everybody for as long as, it takes. And I know we have 2 more folks who are part of our advocacy panel. And then we have 2 other people that had signed up to speak. And there may be some additional people that want to be heard. And I will hear all of you. So I just wanted to make that clear. And I don't know if Ms. Guzman had any other points that, she wanted to finish up.
Solo una más.
Okay, puede continuar.
Si el otro problema es de que a veces le dicen van a pagar $80 al mes y cuando reciben el cobro le llega diferente de 150, entonces ellos no cuentan con ese dinero adicional, solamente eso.
And
Y que gracias por haberme dado la oportunidad.
Okay. And the last point that I have is when we do sign up for health insurance, we are told one amount for our monthly premiums, but when we receive our monthly premium, we end up receiving a higher amount. So we just want to make sure we receive accurate information. And thank you for having me.
Well, thank you. You've given us a lot of thoughts and a number of things, frankly, to follow up on, particularly that, that last point. So we may be circling back to you for some additional information, just to particularly hone in on not getting the right quote and where that may come from. But thank you both for your perspective and your time today. Very, very much appreciate it. And now I'm going to move us to Ms. Vessels, who is a disability advocate, former health educator for the Baltimore City Health Department, former committee member of the Disability and Health Inclusion Programs Advisory Committee. Welcome, Ms. Vessels.
Thank you so much for the opportunity to talk to you today about people with disabilities and to be included in this forum. As you may know, 1 in 4 residents are people with disabilities. When I talk about people with disabilities, I'm talking about people with physical disabilities, mobility disabilities, sensory disabilities, and psychological disabilities. So the whole gamut. For most people with disabilities, core mobility, is the rule and not the exception. That an incredibly high number of people with disabilities are people of color and live in poverty. So those are challenges to begin with, much less the challenges we face. I'm a person with a disability. I've used a wheelchair, a power wheelchair and a manual wheelchair for almost 50 years due to a spinal cord injury. So I've had a lot of time to interact with the medical community. I've also had breast cancer twice and multiple surgeries. Through my own experience, but also as a health professional, I've learned a lot about dealing with the medical profession. One of the biggest challenges for most people with disabilities is attitudinal. Health professionals feel that we're unhealthy, that we're a tragedy, that we need to be cured or that prevented, just because so much is related to their concept of how we have a quality of life. There was an incident recently when people were so concerned about ventilators, and people on ventilators were afraid to go to the hospital that they would lose capacity of their own ventilator because they might be deemed not quality enough life to be able to stay on the ventilator, and it needs to be used for someone else. So attitude is huge. Communication barriers. People who are deaf need sign language. That is their primary language for many people. So they need a sign language interpreter. There is remote sign language provision by many hospitals, but not individual doctor's office and providers of services. And so one-on-one sign language, whether it be remote or ideally in person to get the nuances, is incredibly important. Having materials of information in Braille for people who have vision disabilities or in large print. Many people cannot read the very fine print for the materials that they are given and thus don't read it and don't follow up. And for people with intellectual disabilities, having something in plain English is incredibly important. The language that we use in the medical profession is not necessarily translatable to many people with intellectual disabilities. There's lots of physical accessibility challenges that people have with mobility disabilities. Being able to use a mammogram effectively if you're seated or have a mobility challenge. Using a scale. Most places do not have a roll-on scale. So for those of us who cannot stand and get weighed, proper body weight is really critical for healthcare. Adjustable height tables, especially if you are larger, to be able to get on a table with or without assistance is almost impossible. Most of the exam tables are way too high. And very few doctors' offices or providers of services have these adjustable height tables. Also just basic accessibility. There are still many places, especially in rural areas, where they will tell you it's only 1 or 2 steps. If you're using a power chair that's 400 pounds, it might as well be 2 flights of stairs. They're not going to get into that facility. And when you have limited access to begin with, it's incredibly challenging not to be able to get into a medical care facility because of 1 or 2 steps. Programmatically, there's a lot of challenges that people find when they go to the doctor's office. Insufficient time is allowed. If it takes time to get on an exam table and they've given you 15-minute block of time total, if it's 10 minutes, by the time you get in, you get assistance to get on the table, the doctor's already late and not willing to take the time and energy. It may take more time and energy to deal with somebody with a cognitive disability or just examination in total. May take longer, and those kind of exams are not accounted for. Dealing with the patient and not with the caregiver. Many times folks come with caregivers, spouse, family members, and medical professionals want to discuss the medical discussion with the caregiver, presuming that the person with a disability is not able to understand and to comprehend their own healthcare.
Do you find that similar issues with regard to the insurance piece of things? So, as we talk about not so much the provider community and the delivery of, literally the delivery of healthcare, but as you're talking about insurance and sort of those coverage situations, what would you tell us about what some of those barriers are with regard to insurance?
With the provision of service of insurance, again, there's a lack of understanding of the complexity of what services people with disabilities need and the needs of materials in alternate formats. Our high use of medical care and drugs is incredibly challenging. Finding places that will take the insurance that we have. We often need specialists because we can't go to just a primary care facility or to a basic hospital. Oftentimes they don't understand the demands of the complexities of our medical situations. And so often our medical care is incredibly expensive. And with minimal coverage for many people, that becomes out of pocket. If you're living in poverty and life by nature is more expensive, many people opt out of getting treatment and services. They just can't afford it. Even just the challenges of getting to that facility, transportation costs can be, as you've heard, incredibly high. So a lot of times because we've had long-term dealings with drugs, our drugs become very expensive because take, for example, bladder insurance or bladder medications. You go through the basic ones very quickly and they quickly become ineffective. And so we need more and more expensive drugs to be able to treat bladder infections, which are a huge issue for folks with spinal cord injury and other disabilities. That's just one example of the challenges that we have with insurance coverage covering the basic minimums and not taking into account the complexities that many people living with disabilities and multiple disabilities have to bear. We get through the lower tiers very easily, and then the higher tiers are incredibly expensive.
Now, I appreciate your comments. And one of the things that we're looking at is a listening session specific to people who are living with disabilities. And, if we can, very much like to invite you to come back to talk about, those issues, both with respect to, I appreciate the healthcare, but focusing on, what are the coverage needs, for folks with disabilities that are different than, the average population, and how do we address that? So can we ask you to come back?
I'd be more than happy to.
Well, we would be more than happy to have you back. So, but thank you for your thoughts today, because I think that it's been extremely helpful to focus on that. Particularly, I'm hearing what you're saying about devices, for example, and being able to get devices and coverage for devices and the drug treatments. So thank you, and we will circle back.
Thanks.
And with that, Robin Elliott, are you still here?
I am here.
Okay, so I apologize because, as I keep apologizing for never shutting up, but I'm so appreciative that you were able to come on today. I know that we had asked Planned Parenthood and they had planned to be here, but when they knew that you were going to speak, they said, well, please let Robin speak for us as well. So I am happy to hear from you on their behalf and on behalf of any of your other clients.
Wonderful. Thank you. And thank you for your staying power today on this rainy Wednesday. So thank you so much. So just for everyone else on the call, my name's Robin Elliott. I'm a policy consultant and lobbyist, and I've represented Planned Parenthood of Maryland now for over 10 years. And I wanted to just raise 3 issues related to contraceptive coverage, and to reiterate or underscore a theme that coverage doesn't necessarily equal access. And so the 3 points I'm going to raise are about how maybe we can tweak or look at implementation of coverage to improve access. Maryland has had wonderful contraceptive coverage. We were actually the first state in the nation to require contraceptive coverage back in 1998. And then through, of course, we have the ACA, and then through a series of bills spanning from 2016 through 2018, really rounded out and improved contraceptive coverage. So we have one of the most comprehensive laws in the nation. So the 3 implementation challenges are, it's a theme today, is consumer literacy. It is difficult sometimes for consumers to understand what is covered.
In part for contraception, some of the technical difficulties come in because some of contraception is on a pharmaceutical list and other forms are devices. And then some forms of contraception are actually medical procedures such as vasectomies or tubal ligation. So for a consumer looking for comprehensive consumer-friendly information about all of those options, that can be challenging. And then the other implementation issue I wanted to mention is as part of our Contraceptive Equity Act in 2016, and then some subsequent legislation, Maryland has some really unique and really robust coverage. Two areas that have implementation challenges. The first is our law requires that women can get 12 months of birth control at a time. And so that really means getting, for most people, 13 birth control pill packages. And the reason that is the CDC recommends 1 year's dispensing at a time, because the studies show that if you have that amount of medication on hand, you are much, as a consumer, more likely to be able to comply with your birth control schedule. And that has the effect of empowering the individual and lowering unintended pregnancy rates. That isn't always well known amongst providers, certainly consumers and pharmacists, that coverage provision exists. And so there can often be a lot of confusion about what is covered and what isn't. Similarly, Maryland is one of about 5 or 6 states that requires coverage of over-the-counter birth control. And right now that's primarily emergency contraception, but it could be other forms of birth control in the future. There has actually been some research done on this in terms of implementation. I myself tested it out and found that a major barrier is that pharmacists seem unaware of that coverage provision, and they're really concerned about getting audited by either the carrier or the PBM if they dispense and bill for that coverage. And there's some technical issues related to in billing, the pharmacist would have to put an MPI number in the claims form, and they really need, I think, concrete directions from carriers who I believe have provided it, but it's buried in the hundreds and hundreds of pages that pharmacists need to wade through in order to understand how to process a claim. And then the last thing I wanted to mention, and Michelle Siri mentioned this, and that is the issue of concerns of confidentiality. It certainly affects individuals who are facing domestic violence situations. It also faces individuals seeking contraceptive care or behavioral health care. They're concerned that their EOB will go home to their parent or spouse. And often that means that they either defer care. In Planned Parenthood's case, there's a very notable number of patients who decide to self-pay rather than use that good insurance coverage that we have. If they self-pay, they may be eligible for programs like Title X. And so then public funds end up being used for people who are insured. And we just have trouble sort of grappling with that explanation of benefits issue. I wanted to give a shout out to the MIA. Back in 2014, Planned Parenthood worked with Senator Kelly, who sponsored a bill, and the MIA, as a result, created a uniform form that can be used with any carrier in the state for an individual to request their HIPAA protections. And HIPAA says a carrier has to honor an individual's request to not disclose information in insurance communications if that individual feels it would somehow endanger them. People don't really know about this opt-out provision. The form was helpful in moving that forward. I want to especially compliment the MIA for working with us in making sure that consumer form is in very consumer-friendly language. And that's helpful, but I think we'd like to think about working with the MIA and other partners on really bringing the awareness up about that particular issue, and to see now it's 7 years later, maybe there are other things that we can do to increase the confidentiality of individuals who need it. And with that, again, wanted to thank you for your time and really appreciate also hearing all the other panelists.
No, I appreciate that. And what I'd like to do offline is to get together and talk about a consumer alert. So, we can work with the Board of Pharmacy, we can work with you with regard to these contraceptive issues and the timing, and make sure that folks that are doing the dispensing understand what the law is and what entitlements are. And so sometimes if it comes, from a government agency, it's an easier thing for them to access and understand. So why don't we work on that to make sure that people are getting what they're entitled to? And then I'm also very happy to work with you to figure out ways to make sure that, because I'm not hearing you say that carriers aren't honoring the choice. What I'm hearing you say is that people aren't even aware that they can make that choice, so that they don't have to be concerned about who's reading their EOB and what that might mean, in those relationships. But I'm happy to partner with you around how to get that information to individuals. So yeah, we'll follow up.
That's wonderful. Thank you.
Oh, you're very welcome. So thank you to all of our invited panelists, but we have other folks also that I want to hear from, and who asked for the opportunity to speak, and we're just going to keep going. So the next person who I am very happy to hear from, and I thank you for the time that you've spent and your patience, is Pam Limberry. I hope I pronounced that correctly, who's a program counselor at Upper Shore Aging. And we're very interested in hearing what you have to say about sort of the insurance as a way to access healthcare and what some of those barriers and gaps are.
Commissioner, Ms. Limberry had to drop off, but she emailed her comments. So we have her comments.
All right. Well, we'll definitely circle back. And then I think there was a Tabitha Henson. Is Ms. Henson?
We're not seeing her here, but there is someone on the phone. So if you're on the phone, Ms. Henson, please unmute yourself, and I will, Ms. Henson. So no, I don't think she's on the phone. So.
Well, I apologize. Now, I don't know that we saw anybody in the chat who asked for the opportunity to be heard today.
We did have a question earlier.
Sure.
From Alicia at St. Hill. So Alicia, if you would like to speak.
Hi there. Thanks for having me. My name is Alicia St. Hill. I'm the Senior Manager of Benefit Policy at Kaiser Permanente Mid-Atlantic.
Hi.
Thank you for the opportunity to sit in on this session. It was really enlightening, taking lots of notes. I had a question for the panelists as they talk about insurance literacy, which is something we're obviously concerned about as well. I was curious if it sounds like, and because I asked this quite earlier in the session, but it sounds like individuals are not familiar with the benefits available to them as a preventive care service either. And so I was curious from panelists if they could respond to the question if it's clear to them that people don't understand that there are $0 benefits even in a very high deductible plan that would offer routine preventive care at no cost.
So maybe the efficient way to do this is, if you were a panelist and you're still on the phone, if you want to just raise your hand, and then that way we can go, and maybe Craig could call on you so we can go in some sort of a order.
Raise the hand is at the bottom of the screen. So if you'd like to do that.
And I expect Michelle may have some thoughts about
yes,
that.
Yes, Michelle.
Well. You want to go with that, Michelle?
Sure, I'm happy to. Health literacy has been an ongoing challenge, and it's something we find all the time. And as much as we think we're doing, it's never enough. So we dedicate at the exchange a lot of time and resources to health literacy. We even partner with the Horowitz Center for Health Literacy in an effort to really try and identify better ways to communicate. And I wish I had a great answer for it, because one of the problems that we have, and we continue to try to talk about all the time, is just that you have health insurance and that there are mandated benefits that are no cost. Medicaid is free insurance, and many people don't recognize it. So I think just as a community of providers, we all just have to continue to talk health literacy and communicate at all levels that there are programs available, and co-pays and deductibles, what those are. Of course, we have at the exchange, we created value plans after hearing loud and clear from consumers that just what we've heard today, I can't afford to pay $200 a month for health insurance and then have a $6,000 deductible. So the value plans cap deductibles and also offer services pre-deductible, or we really are working with the carriers to get those to be co-pays and not co-insurance. So a lot of mechanisms to help folks understand that health insurance does provide value, but that is one of the challenges as the exchange. If we're asking someone to pay for health insurance, we need for them to understand the value in paying for that.
Thank you.
Any other comments?
I'm not seeing anyone.
So with that, I'm just so appreciative of everybody who participated today, for sharing your experience, for sharing your stories, letting us know what the issues are, both with respect to health insurance, but obviously with respect to access to to the connector and access to healthcare in general. Because even if it's not precisely with respect to health insurance, it's all part of the same mix. And even if it's something that I as insurance commissioner, for example, can't do anything specific about, there are other places where where we can carry your message for you. So I really am thankful for the time that people put in today. And my expectation is that we will have lots of follow-up with a number of people. Part of what these exercises will drive are more consumer education from the MIA, and will also drive additional what we call Ask Mia, which is our virtual open house where we invite consumers to come online or to call in and get more education and more information. So we will put what you've taught us today to good use. So with that, I thank you very much, and I look forward to seeing some of you in some of our future listening sessions. Actually, probably all of you. So thank you.
Thank you very much. Have a good one.
Thank you.
Welcome.
Excellent.
Great. Thanks. Bye-bye. Stay safe.